sir. We are live.
Okay, thank you everyone for joining for this ASCO update, which we have been trying to do it as an update every once in 6 months. And this only update, what we wanted to do is only discuss about the recent updates and related to breast cancer. And we will be having the abstracts which you have chosen from the ASCO 2025 and ESMO 20 Breast 2025. So we have put it into 2 days, day one and day two. And day one, we will be trying to discuss what important abstracts were discussed in last 3 months and what has been discussed in last 1 week back in ASCO 2025. And we will have three moderations. So first will be the hormone positive, then we'll have a HER2 positive, and then we have a triple negative. And in between, we thought that why not put something that will interest all of us and we'll become better to analyze trials. So we have the talk of Dr. Senthil, who will be speaking on statistics, and we'll be specifically restricting this time to the non-inferiority trials. So without much wasting much of time, we will have Dr. Randeep, who is going to moderate the first panel. Two, three housekeeping rules. First, we have the Zoom link open. The faculties can speak and also chat, but we have the Zoom link for the delegates and students, which we wanted to target specifically, who can interact with the faculties via the chat. And if there is something as a difficulty which they are finding, they can always, they are free to message me or WhatsApp me or Tarun or the contact team on an email. We'll help them out. And Dr. Randeep, we have 35 minutes for the panel, and we also have kept 15 minutes at the end of the day for anyone who could not discuss, or we have something else left that we will discuss at the end of the session, that is a 9:15 to 9:30. So that's how the things will be. So please, Randeep, you can start your panel, which will be a hormone positive early breast cancer, and let's look into what exactly has changed in the last 2 to 3 months. Randeep.
Vedanta Ahmedabad, Dr. Shefali, the co-host. Okay, the Dr. Shefali, she is from Max Delhi. Dr. Panda, he is from Bhubaneswar, some hospital, and Dr. Biswajit, he is from Pondicherry. So we have Bhubaneswar, Pondicherry, Delhi, and Ahmedabad. Sahu has very beautifully covered. So in next 30-35 minutes, I have taken very simple abstracts, but what we want to deliver or what we want to discuss is, to my mind, the theme is of adjuvant endocrine therapy. But let's see that it is like an old wine in a new bottle. So let's see what in last 2-3 years we have been discussing, or last 5 years, what has changed in this 6 months. And we all know that in last 1 decade, whenever we have been talking about adjuvant endocrine therapy, we have been discussing about T size, N size, Ki67, ERPR. I mean, these are the same things, genotype markers. And those of us who are old and even older than me, like Chirag said, they are all know this is almost a decade discussion. So let's start with these four abstracts, and I think we all know these abstracts, but some few nuances have evolved, especially the soft and text, almost 10 years old now, 15 years follow-up is there. Natalie, 4 years follow-up is there, and then there is a subgroup analysis of Natalie post-stratified by the age and the menopause status, and something from the positive trial, which is interruption of adjuvant endocrine therapy. So what pattern I will do is, in 1 minute, I will try to present 2-3 slides of the abstract, and then we will take the discussions points from the experts. So the soft and text was, we all know soft and text. So this, I will directly come to the results to save time. This is a 15-year follow-up. DFS was the primary endpoint. DRFI and OS was the secondary endpoints. When we compare soft with chemo and without chemo, the tamoxifen plus OFS and E plus OFS use, I don't find much difference of tamoxifen versus tamoxifen plus OFS, whereas when we come to exemestane, there is a big jump compared to single agent tamoxifen, whether we talk about DFS or DRFI at 15 years, as well as when we talk about OS in prior chemotherapy subset, that is the patient which is higher risk. there is around 2.5 delta difference of 77.4 versus 79.8 in the overall survival at 15 years. Whereas when we come to no chemotherapy subsets, this difference disappears. And this is also seen even in the soft as well as in the soft also there is a around 2.5 delta, and in the text also there is around a 2.2, 2.3 delta in the overall survival. This was a joint analysis, and if we compare the T plus OFS versus E plus OFS, there is a 3.9 delta, and this delta becomes almost double when we come to prior chemotherapy subsets, which is 6% delta. Coming to the age, the moment we focus on the slide of less than 40, the delta in the distant relapse-free survival is around 7.4, 7.6%, which is too huge to my mind. And the moment we cross 40 or 45 or precisely 45, the dip is rapid from 7.4 to 3.8 and then 2%. And in the overall survival, similar things are seen, a delta of 3.8% in OS, though not statistically significant, we all know that, in very young populations such as less than 35 years. So starting with this, we'll start with Chirag sir, and then Shifali, and then Panda, and then Dr. Biswajit, and we all can comment. Three comments for this abstract. What is the relevance of this data after we have Natalie and Monarch? And to your mind and to my mind, I was thinking after seeing this data, if we have to escalate adjuvant hormone therapy, keeping CDK side for the time being for the discussion of this point, is it relevant that we give tamoxifen OFS, or tamoxifen plus OFS is completely out and we just focus on E plus OFS only, provided we are planning to do ovarian suppression in premenopausal females? And the ideal candidate to your mind in 2025 in your practice for soft and text. Chirag sir first.
So, looking at the first sentence, the relevance of this data after Natalie and Monarch. So, I will tell a broad sentence that if we look around, we feel that nothing has changed. But if we look back, we feel that everything has changed. So, that has been happening every few years in oncology, and particularly in hormone receptor positive early breast cancer as well. But if you look at what's going to happen in next few years, that will put the things in the real context. That now we are looking at Natalie and Monarch, but few years down the line, we have oral SERDs which are coming up in the management of early breast cancer, and for at least PARP inhibitor in BRCA subset also is coming up. So how to sequence these drugs appropriately, that is something that we need to find out. So one very basic question that needs to be answered, that is not yet fully answered according to me, is how to define the low risk patient for whom just 5 years of tamoxifen is good enough, and then progressively what all should we keep on adding. The first thing to add is ovarian function suppression, and then replace tamoxifen with exemestane, then add CDK4/6 inhibitors, and then go forward as the data matures. So it is of course relevant to keep on looking at all the past data as well.
Okay, comments from Shifali, whatever Chirag sir has that for the interest of time and for everyone, let's take your view without including whatever Chirag sir has said.
Okay, perfect. So I have few understandings from these trials. So of course, neither of the option is completely out. So there is a scenario for every option. Say we have somebody with genomic low score, we premenopausal female, stage 1, grade 1 or 2 disease. I think tamoxifen only option can be considered here. Now, if somebody has a higher risk where subset does not involve inclusion of chemotherapy, then you can have the option of TAM plus OFS, because we saw the patients whom chemotherapy was not required, say T1B N0 types or T2 N0 types, where TAM plus OFS can still be an option. And now there is still higher risk group where either we require a chemotherapy or more than four nodes positive, or the size of the primary was larger, say more than 2.5 centimeters. We know that these are higher and still higher risk group. So, if I conclude a pyramid, so starting from tamoxifen in the lowest risk to TAM plus OFS in certain subset to exemestane plus OFS and add on CDK4/6 to the still higher group. That is how I would escalate the treatment like. But of course, we don't have a one-line answer for each and every situation because there are no guidelines or certain set protocols suggesting that how to go about these. That would be my take on it.
Okay, Dr. Panda.
First question, relevance of this data for Natalie and Monarch. There is no clear-cut answer. We don't have evidence as of now. CDK4 6 plus OFS, we don't have that. NRG trial is coming up on NRG offset trial. So that is looking into CDK4 6 inhibitor. As of now, we don't have a clear data. Where we can use it in Indian context. Many patients are still not able to afford the Monarch and the Natalie. So in those patients, definitely we have got data that we can use that. Coming to the second question, tamoxifen plus ovarian function suppression. If somebody who is having a T1N0 and it's a grade 1 disease, age is more than 40 years, Ki67 is low, probably in that particular subset, we can use tamoxifen plus OFS. Exemestane plus OFS, somebody who is really in a high risk, so N2, N3, so, and it is a high grade. So in that particular situation, we can use a exemestane plus OFS or a high Ki system. So this is the composite criteria is there. So while looking at the exemestane plus OFS, we have got a composite criteria which looks into this particular clinical and biological factors and then takes into account.
Okay, Dr. Panda, there was some blurring in your voice. If you can log out after this comment or just try to just log in or log out again, or maybe can Shifali, you confirm the voice was clear or it was only with my connection?
No, it was little blurred, I agree, but most of the
No,
things
just
we
take
could
care of
make
your
out.
connection. But we could understand what you wanted to say.
Right.
And Doctor, the last comment from Dr. Biswajit on this abstract, then
Yeah,
we move further.
thank you, Randeep. I just have one comment. I think most of the experts have told. One practical problem is using using a GnRH analog. We all know that breakthroughs happen, and if you do not aptly give the injections monthly, 3 monthly, all has been a debate. So we should keep in mind about that too, in practical purpose, whether tamoxifen is easy to do with OFS rather than doing exemestane with OFS. So definitely less than 35 T4 and 2 disease, I would go with exemestane. Otherwise, we should be okay even sometimes doing tamoxifen so that we don't have this breakthrough.
So what we will do, we will come back to this question when we discuss Natalie of how to incorporate soft text data with Natalie 4-year or with Monarchy. I think that is what Chirag sir as well as other experts were trying to convince that how we can. Let's go to that Natalie abstract. It is Natalie. We all know the trial design. I think I can omit that in the interest of time because we all know this is. This was presented, I think, in ESMO. Yes, this was an ESMO 4-year update. I will directly come to the 4-year IDFS data. The 4-year IDFS data, the delta is 4.9%, and we will also see how it divides into node positive, node negative. And simultaneous curves are there of Monarchy, though I know we can't compare Natalie with Monarchy. There were two different subsets, and the Natalie had much earlier patients, have much even node negative and even N1 without high risk features. So the delta of here was around 6%, and here it is around 5%. Also, we know that we were focused. We as a community, we were more focused on node 0. What happened to N0? We will see in this curves. These were the updated curves of N0, where the delta was still 5.1%, because many of us still think that the hazard ratio, which is highlighted on this slide, is very wide with a very wide confidence interval, and the hazard ratio is crossing unity in this N0 subset. Again, it's a subset analysis. The confidence interval is going from 0.4 to 1.1, and that has crossed unity as well as wide interval. Whereas the moment we shift to node positive subset, it is 0.6 to 0.9, which is a very standard hazard confidence intervals and hazard ratios. And similarly, the stage 2 and stage 3, the benefits are there, but the more focused discussions are for N0 here, as well as for the 4-year update, because I think now at this point, we can't say earlier we used to say, and even in the ASCO update, which was 2 years before, has mentioned that if the patients are eligible for both Monarchy and Natalie, then we may go for Monarchy because the follow-up is longer. I think 4-year subset, 4-year follow-up does give that confidence that if the patient is eligible both for Natalie and Monarchy, it is becoming difficult to choose. And then this is not from that. This is from one of Dr. Senthil's side, if he is there, and I shall acknowledge that I have taken from his one of his OBTO presentation. And the perspective is, this is just to add to the discussion once we take the comments, that when we talk about number needed to treat and calculate that, it comes to 13 in monarchy and 30 in Natalie, which is almost 2.5 times. And the toxicity wise, the grade 3 events are 50% in monarchy and around 62% in Natalie. So with this, we will again follow the same comments from all the 4 experts, starting with Chirag sir, and then Shifali, and then Dr. Panda and Dr. Debashish. So, sir, with this follow-up, Chirag sir, all N1 patients eligible for Natalie and Monarch, is it much choice left, or you will be still focused on Abema and not Ribo?
So, Abima has 5 years follow-up. Ribo has 4 years.
6 years, yes, 6 years now. Sir, the
Yeah.
trial has started. This will be always,
Yeah.
there will be always a 2-year difference, because the trial has started
Exactly.
earlier and they have
Exactly.
reached their endpoints and analysis. So that 2-year gap will be always there. So till what time we will keep on having this partiality? Maybe after 10 years or 12, 15 years update of
Not kidding. Not
Monarchy
kidding.
and Natalie, we can always say, no, the 13-year update, 15-year of Natalie has not come and Monarch has come. That is,
No,
that is why I put this question. Yes.
what I was trying to tell you is that for both Abima as well as Ribo, the follow-up is relatively short, and I won't buy any of them, particularly with lower risk category, because in lower risk category we keep on seeing delayed relapses, and we need to see whether any of this addition for initial 2 or 3 years, whether it is able to prevent the delayed recurrences or not. For higher risk group patients with N2 and onwards, it is understandable that patient may have early recurrence, and if we can demonstrate improvement in the event-free survival at 3, 4, 5 years, it is worth accepting in our practice. But not for the lower risk, not for N1, grade 1 or grade 2, or N1 with ejection with KI67 less than 20%.
Okay, fine, sir. I think you have answered these two. The third question, T2N0, which is either grade 3 or genomic risk and Chi more than 20. This was included in Natalie.
Yeah.
Are you okay to use it with this N0 curves? I will just go back. I mean, you know the curves and the confidence interval with this one.
So,
Or, or you will go with soft and text 15-year update and just restrict yourself to E plus OFS in this subset. That's why I said that we will come back to this soft text. And that particular question is for T2N0 grade 3 high genomic risk, P more than 20, sir. So for this tomorrow morning, patient is fit, affordable, compliant. You will go with Natalie or soft text?
So with N0, I will go with soft text rather than Natalie.
Okay, okay, sir. Fine, fine. We will take comments from Shivali. Shivali.
Yeah.
I
So
think the
again,
third is the difficult question. First two you can take, and
yes.
then third we need separate comments from your side.
Okay, sir. So for N1 eligible for Italian monarch, I think in N1 subset, I will more rely on the toxicity concerns and these kind of things, because Ribo with a reduced dose showed much, I mean, almost equivalent efficacy and no compromise. Toxicity was less. So I think I would choose it here. When it comes to the N2, N3 subgroup, I think more high risk patients were included in the monarchy trial, and then because majority was stage 3 here, so where we want to focus our concern. And in this situation we have more robust data, more long-term follow-up with Avima. So I think there we can always argue, but whether it is worth relying on only on that ground, still questionable. So that would be my answer in first question.
And Shifali,
Sir,
this will
please
be
can go to
combined with,
second.
sorry to interfere, this will be combined with softer text.
Sir,
N2
in
N3, N2 N3.
monarchy in monarchy, to my understanding, only 20 to 22% received ovarian function suppression. We have more of OFS suppression group in the Natalie. So we have more answer there, that over and
So we will
above
come. That is
OFS.
actually the third abstract. So I think that we will
Okay.
come. You are right. I will come
Perfect.
to
So,
that is the third abstract.
so
Status.
yeah, so I would base my decision on that ground. So then the second question where you asked that T2N1 group KI67 less than 20%. Absolutely, that was not included in Monarch. So again, the choice is Ribo here. And the third thing is T2N0, where we actually see whether only the OFS plus AI versus adding on the CDK4/6 would help. So again, it is not a yes and no, but I will see that if the patient is less than 35 years, you have larger T, I mean, this T2 maybe, I mean, we have varied from 2 to 5 centimeters. Then we have high Ki67. There are certain clinical risk factors also. And if, I mean, you have already written that high genomic risk. So on a case by case basis, I think I would definitely prefer to add CDK4/6 inhibitors, not in a blanket statement, say like the previous panelist also in last question answered, if she's 45 years or 42 years, and we can achieve that OFS and AI can give us that benefit, then I think I can on case by case basis decide. That would be my choice here.
Okay, I think we will come to third question directly in the interest of time, since the first two are more or less a very generic question. Dr. Panda, third question comment. And we have a comment from Sahu that, yes, do we have a data for benefit and high genomic risk? Natalie had a very small subset of high genomic risk. That is what Sahu is pointing. And my
Yes.
question is actually pointing down to a very low subset. I can't put a number, but it will be single digit. And that is what was in my mind. And Sahu wants to say that a T2, N0, and then a high genomic risk will be actually in a single digit patient numbers, though I don't remember the numbers offhand. If Sahu can put it in the chat. Dr. Sahu, sorry. And then Dr. Panda, in the interest of time, third question directly, T2, N0, either grade 3 high genomic, Natalie or soft text?
So mostly means I'll go kind of a softer text. Usually, if I don't use T2N0, mostly I don't. Means most of the patients that don't do a genomic risk based only on grade 3 and Ki, I don't offer them.
Okay, fine. So, Dr. Biswajit.
Yeah,
Biswajit,
I
your
just
comment.
have 2 points on this 3 questions.
Sure. Yes.
The first one, that about the N1 patients, all N1, I'm not sure whether we need to give Abima or Ribo. So maybe T3 N1 and above, like in Abima trial, which they used. So that is one. And obviously 2 years versus 3 years is one more thing which we can consider. 2 years is enough in Abima, so duration will be lesser. Coming to the third question, in the third question, most of the times we also give some chemotherapy. If you go by the genomic risk, all these patients should also receive, more than 26 should also receive chemo. So now the question is whether we should actually give chemo or don't give chemo and just do the ribo with hormone therapy is something which is interesting, which we need to answer. Otherwise, if I am going to give chemo, then I would go by soft X. I would not do the give the
Okay.
additional
So
CDK.
what we will do, I know the in the interest of time, we'll go to the third abstract and we will come back to exactly the same third question. And that abstract is about menopause and this was ribociclib in the menopausal status. This is, I think, not a very clear slide. I hope it is, because this is a snapshot of I think from some Twitter or this was ASCO 2025 presentation where the subsets analysis was presented for the Natalie for premenopausal and postmenopausal. You can see the curves here and the confidence interval, but more detailed is in the next slide. So this is less than 40, more than 40 in premenopausal. You can see the delta difference of around in the IDFS, which was the primary endpoint, is 6.3 versus 5%. And when we talk about other disease-free survivals, distant and relapse-free, there is in some subsets, there is a difference of around at least delta of 2. Similarly, in the postmenopausal, the numbers are not very good, especially in this less than 60 years. I think it is more of a number game. I don't know why there is so much of difference. If the experts can help me. In less than 60 years, the delta is 2.6, and in more than 60 years, the delta is 6.4. And this is across the different analysis. I first thought it may be the numbers, but if you see, the numbers are not bad. It is 700 in each subset. So I don't know why this difference is coming. And the last, before we take the comments, discontinuation rate is almost double in more than 60 years. Still, we are seeing this benefit. If you see the focused row, the discontinuation of ribo is around 16 to 17% in the premenopausal females. But the moment we go to elderly or more than 60 years, the discontinuation becomes almost double to 27%, or almost 1.5 to 1.75 times. And now we come to the same question. T2N0 grade 3, high genomic risk I20. With this data set, maybe less than 40, and the usage of ctDNA or ER, low ER or other, I mean, these are the points which may help to decide whether we go for ribo or not in our practice. We can again start with Chirag sir. I think sir must have got my thought process. Before we take the comments, the one last slide, and this is actually quite, quite intriguing to see the ctDNA coming into Monarch E. This was not presented in this ASCO, but in Monarch E trial, if you are the blue curve, which is doing the best, is one which is persistently ctDNA negative, and one which is a gray curve here is the one which is persistently ctDNA positive before starting and even during treatment. And then we have the others who become positive and they do really badly. And this is over 3 to 4 years. And you can see that there are stark differences between blue, which is persistently negative, versus the gray, which is persistently positive ctDNA. So with this, sir, you help us with these abstracts and data, these are all recent data sets. T2N0 grade 3 high genomic risk. Are you okay for using ribo in a maybe less than 40 years pre-menopausal female with a ctDNA positive and a strong ERPR, sir?
So, with ER positive, PR negative,
Yes,
maybe.
ER positive, PR negative.
Right. But for all other risk factors, we need more and more data. So I will tend to use ribociclib for this subset with high genomic risk or high Ki67 and so on and so forth.
We have quite a good number. I mean, I understand here there is some discrepancy between 230, 870, but 60 and these are quite a good number of 700 patients in each subset coming here for the NATLI. I mean,
So
this is a huge trial, so we can talk about the subsets here.
yeah, but I mean, how many of these patients were T2N0? I mean, that is something that we need to find out.
Agreed. That we will not know.
So,
Yes.
with N0, we still need to keep on looking at that. For the information of everyone, an adjuvant wider trial is started by Novartis. That is going to happen in some centers in our country as well, and that's in public domain. So I don't have any problem in disclosing some details about that trial. Initially, it was supposed to enroll 3,000 patients, and now it is supposed to enroll only 1,100 patients, and they're restricting on the subset with N0 patients, and they want to look at the result of N0 patient in a fewer number of patients. Not sure whether they are looking at any sort of futility in enrolling these patients or not. But let us see what comes out of that trial as well.
Okay, sir, we have, I think, 8 minutes left. Shifali, very brief comment.
Yeah. So I think
Will you use
the
ctDNA tomorrow in your practice? I will ask specific questions so that we can cut down, because the last abstract.
not right now, sir, because I don't know how to. Okay, prognostication I know, but what to do with this ctDNA, I don't know. So
Okay.
as of now,
Fine.
no.
As of now, no. You will need more data. Okay, Dr. Panda, will you use in a young female, say 30-year female, T2N0 grade 3, premenopausal, able to tolerate, will you use ribociclib? Let's forget about genomic risk. That looks to be more attractive. Just focus on T2N0 grade 3, key more than 20, and a
Yeah,
young premenopausal female.
yeah. So I have already discussed in the last slide also. So these patients are still I'm not offering them the ribociclib.
So you will not. Okay. Okay, fine. So I will go to the last abstracts and we will start with Dr. Biswajit's comment. That is a positive trial. I will take 1 or 2 minutes to understand what they did in this abstract, which was really interesting. So we know positive trial, we are all aware this was around at least 24 months of adjuvant endocrine therapy, 3 months of washout, then 2 years gap where we allowed conception, delivery, breastfeeding, and then starting endocrine therapy again. The primary endpoint was number of breast cancer events and not pregnancy. That is to be remembered. And there were stage 1 and stage 2. Basically, the trial said 1, 2, 3, but it was a stage 1, stage 2 trial. Use of artificial reproductive techniques, ART, was allowed. And this was compared with a cohort of soft and text. So these are the results. These were presented in 2023. This was not the abstract. There was not much difference in the breast cancer events over a follow-up of 3 years, which is a short follow-up. Median follow-up is 3.5 years. And there is 8.9, 9.2. And the pregnancies which happened, 70% of pregnancies could occur in 2 years, and 40% used ART. 86.1% were live birth full term, and there were one stillbirths and some miscarriages. Now, what they did in this was again a ESMO breast cancer abstract, was to assess and see that whether we can predict that what are the ovarian reserves and whether we can allow them to go to this trial or not. And they did a AMH, FSH, and estradiol study at 3 months and defined AMH less than 5 as low ovarian reserve, either at 3 months or 12 months. Then they did an premature ovarian insufficiency definition of FSH more than 25 at 12 months. These were the major two definitions which have been discussed from this positive trial in this abstract. And then the low ovarian reserve was seen in 50% of the patients, and majority of them which had low ovarian reserve in the percentage basis that was in the bracket is more than 40 years. And in spite of, what is interesting is that in spite of around 50% low ovarian reserve, there is a pregnancy rate of 75 to 76%. So one of the things to the mind are that many people, why this is being discussed, because I did had a discussion with our fertility specialist that when we send them for fertility and stop endocrine therapy, they do AMH and all these analysis, and then they decide whether to go ahead or not. Also, the patient who received chemotherapy, there were 62% low ovarian reserve and a 16% premature ovarian insufficiency, which is also called premature ovarian failure. And the last thing is, which is very interesting, is that if you have given GnRH analogs, there is no difference in low ovarian reserve or premature menopause. So if we are putting them on a Zoladex, or we want to give OFS with OFS with Zolad, TAM plus OFS or E plus OFS, they're still eligible for positive trial. And there were other analyses which were presented in this abstract. And this was a May 25 abstract of ESMO breast cancer. And if you have a low ovarian reserve, you have around 50% chance of getting pregnant. If you use artificial reproductive techniques, 2.5 times more are the chances of getting pregnancy. Moment your age is more than 40, your chances of getting pregnancy fails. So these were the odds ratios and the regression analysis, multivariable regression analysis, which was used to see that if you are thinking of doing a positive trial and counseling the females, these were the factors which come to the mind, and these are the AMH FSH levels which decides that how long you have to keep the patient waiting, or whether you can wait for 1 year, 2 years, 6 months, and how long you will hold endocrine therapy before she becomes pregnant. So we will start with Dr. Biswajit. Do you practice, Biswajit, positive trial or not?
Yeah. So
Okay.
in practice, yes, definitely. We need to at least wait for 2 years before we tell the patient that you can conceive and have the pregnancy undergo.
Hmm.
So the
And if you practice
duration,
positive trial, my concerns are that I tell the female today that yes, you stop it. 3 months wash off period goes, we allow that, yes, please try, or try the family, and start consulting infertility specialist, give a 3 month washout, then use the techniques. 1 year passes by, 1.5 year passes by, till how long you will wait?
so I think 1 year is the time. I think because 9 months is the pregnancy time and 2 years beyond, we are not sure. So I would wait for 1 year. And then after 1 year, would again explain to the patient back that beyond this, we don't know what will be the risk of you developing recurrence. So that risk, then the patient has to decide. But 1 year would be ideal. I think that would
And
be
the
a
last
good time
question
point.
is, seeing this abstract, do you feel you will rely on AMH and FSH? AMH at 3 or 12 months, or FSH? Though I know the fertility specialist
Yeah.
also has to answer, but if we have some knowledge about these abstracts, we can be more wise in discussion. Because what I have realized, that once you are dealing with a malignancy, the anxiety of the infertility specialist is even more than us. And they are not much
Uh,
aware of this positive
yeah.
trial data. That is why I thought of discussing this.
Yeah, I think this is a very good present. I mean, the data looks good that even if you have a low ovarian reserve, you still have a 50% chance of having a pregnancy. So I think there is no need to check, because irrespective of that, you have still a chance of 50%. So I don't think we need to too much get worried on the low ovarian.
Fine, that is your take. Okay, Dr. Shefali, your take on this.
Yes, sir.
I think
So,
the second positive we all would like to do, the second and third. How long will you wait?
okay.
And how will you use this abstract in your practice, the AMH and FSH and this data set?
So if my patient is a candidate for positive, of course, 1.5 year timeline, I would prefer to wait, because she needs to have that washout period, then she needs to try to conceive, and then the pregnancy time. So I think that much time I would allow to wait. And of course, AMH and other things do matter. I don't know 44 patients data, how can we take it more forward? It's a 3.5 years follow-up, though it's an impressive thing. And one thing more was in my mind that though we have BRCA positive patients also who can conceive, that data is also available, but we know that BRCA positive patients have already low ovarian reserve. Now, how much this impacts and how many patients were still BRCA positive here and who did conceive irrespective of AMH, we don't know. So I would definitely
BRCA were
consult
positive in this trial. BRCA positive patients were included. I don't remember the exact percentage, but 100%
yeah,
they were
percentage
included in
I
this
also
trial.
sure. And then this is impressive. So my take on this trial is if somebody is very keen on having the pregnancy, should not be denied. After explaining all the caveats and the shorter follow-up, still we can offer the patient the practice based on this trial.
Okay, Chirag sir, your comments of whatever they have said, apart from that, anything extra? I think the question which comes to the mind is if AMH is actually less than 0.5 or FSH is coming into more than 25, will you still allow some more time period if the infertility specialist asks us? That is the important question from this trial.
Yeah. So working with the fertility specialist, I will keep on looking at the values of AMH and FSH. It's a dynamic thing. It's not a static thing. So if at the end of 3 months, 6 months, 9 months, if the values are declining, then the chance of pregnancy remains glim. And I will ask the patient to withdraw from that trial earlier rather than completing the full 1 year. I won't ask the patient to continue trying for pregnancy beyond 1 year.
Okay, fine, sir. I think we have reached our time. Only 1 minute is left. Dr. Panda, your comments, anything comes to your mind for this abstract?
So minimum adjuvant hormones has to be 2 years. They had taken after 18 months also. So one thing is that after 2 years only I will discuss with them. 3 months of passing out period, and then we'll continue for another 1.5 years, giving them an option for going ahead with pregnancy. Serum AMH, that has been multiple papers looking into that. It is a good ovarian reserve, but this paper looks reassuring that even if AMH is low, still they are able to conceive. So definitely, I will work with the infertility specialist, and then we'll take the discussion forward for having a pregnancy. There are multiple papers for germline BRCA. We can select out embryos which are G-BRCA negative and then implant that. So there has been multiple papers that even G-BRCA positive patients, they can go to the pregnancy very safely now.
I think in the interest of time, I will just conclude the discussion. And
Can I ask? There's a chat question. AMH
I
is
think we can take that also, because if we have 1 or 2 minutes, we can take.
we will take that. That the AMH is 3 month washout sufficient? Does anyone has idea on that? For after LHRH agonist, will that washout period of a 3 month be okay? What do the experts feel about it? Or Randeep, you can take it.
I think the idea of this abstract was Dr. Dr. Biswajit said very classically was that even if your AMH is less than 0.5, still you will conceive, because if you see out of 438 patients which were included in this analysis, 50% are having, as per the definition, low ovarian reserve. Still, there is a 78% pregnancy rate. So as such, AMH is considered as less than 0.5. Sometimes people say less than 0.2 as postmenopausal. And many people do believe that if you are on exemestane, I think this question comes more important of AMH levels less than 0.2 or undetectable or less than 0.2 as postmenopausal if the patient is mainly on aromatase inhibitors. That is what we have been using AMH values for. But here, I think AMH value, even if it is less than 0.5, I will still tell the fertility specialist to please consider pregnancy, and we can easily wait for 2 years.
Okay. You can go to conclusion slides, and I will only request you after your panel is over, you can answer those 3 questions which are on the question answer chat.
Fine. I think in the interest of time, what I will do, we can go with the Dr. Senthil's talk, and I will answer in the question answer with that, because it is already 7:40.
Yeah. Thank you.
Fine. Okay.
So you can conclude. Randeep, you can go to okay. That's okay.
Okay.
So sir, Randeep, you can. The chat is open, and you will answer those both in the chat and in the Q&A. You do that both for us.
Sure.
So we will now go to the discussion that we wanted to have, and we are continuing it from the first deep dive. We are going into the second one, and still we want to have a discussion statistics every time. That's the intent, because that's what we all need to learn as medical oncologists. So who better than Dr. Sendil Rajappa? All of us have heard him quite a bit. We see his smile. I know that. But what we'll be having is he's going to talk on non-inferiority trials, and we have tweaked the topic to is not is good enough. Uh, is it that is as good enough, and can we do it? We have just tweaked it to what the non-inferiority actually put it across, that okay, it might not be good enough. So Dr. Sandil, 30 minutes, and we would like to hear you out.
Thank you, Sahu. Sahu, will you warn me at 20 minutes?
I will.
Yeah, at 8 o'clock, you just give me a bell. So that
Yeah, sure.
Okay. Thank you, Sahu, for asking me to do this talk. For some reason, good or bad, I've become your statistics expert, it looks like, while I'm actually not one. My knowledge of statistics is extremely elementary, and I've tried to read up for the sake of this talk. Just like the last year, I'll do my best. But if you find something inadequate, or if you have a doubt that I'm not able to clear, I'm more than happy to read up and clear it for you sometime later. Sahu gave me a couple of other titles for this topic. I specifically choose this one with a little bit of modification in the title. And there's a small flaw in this title, and I specifically created that flaw in this title to impress something specifically upon the audience. And as I go by, I'll tell you what that flaw is, or rather you will yourself realize what that flaw is, while I will still point it out for you. Now, there are generally three broad study designs. One is called superiority. That means you're trying to prove the superiority of one intervention compared to the other. And then there's just equivalence and non-inferiority, which we will discuss in detail today. We'll come to the difference between equivalence and non-inferiority very soon. Okay, it's dinner time, at least for me, if not for you. So I thought I will start with this example. Now, you finish your work, you've gone home, you're really tired, but you want to have a Hyderabadi biryani. The one on the right side of your screen is the standard so-called, top-class Hyderabadi biryani that most of you would know or have heard of or tasted. That's the Paradise biryani. Okay. Now, the rating for this biryani is 9.5 out of 10, Zomato, Swiggy, whatever you generally look at. The one on the left is biryani from Pista House. Now, Pista House biryani is a tad cheaper compared to Paradise biryani. It's closer, so your delivery is likely to be faster. But the rating is 8 by 10. Now, what would you do? Would you still wait for the standard Paradise biryani? It's okay to do that. But a lot of you, I would think, since you're tired, you're hungry, you don't want to wait for that longer period for that biryani to be delivered, you would just think strongly about delivering or asking for a Pista House biryani, because maybe it's a little worse compared to Paradise biryani because of all the other advantages. You are prepared to forego that 1.5 additional points that Paradise biryani has. So you're making a compromise. You're accepting it even though it's a little worse compared to the standard. And that is exactly what is non-inferiority. Now here, Paradise is 9.5, Pista House is 8. So that's 1.5 points, by which Paradise is not much worse by. Okay, each of these words are very important as I am pronouncing or saying them. So you're trading off this margin of 1.5 points in taste for the sake of all the other advantages that you're getting with the Pista House biryani. So this margin of 1.5 is referred to as a non-inferiority margin. Okay, so you have a standard, you have an alternative, you want to choose the alternative to the standard, even though it may not be as good. That's not the right thing. I'm saying that again because there's a flaw in that statement. You're accepting it even though it's a little worse because of certain other advantages that you're getting when you order the Pista House biryani. So that's a concept that's important to keep in mind. So let's compare the designs. A non-inferiority design is to demonstrate that a treatment is not inferior to control. Okay, remember that it's not inferior to the control. So in statistics, you always have a null hypothesis and you have an alternate hypothesis. You always reject the null hypothesis. You don't prove the alternate hypothesis. Okay. So the null hypothesis for a non-inferiority study is that treatment X is worse than treatment Y for a given condition by greater than delta, which is a small difference. The alternate hypothesis is that treatment X is not worse than treatment Y for a given condition by greater than delta, when delta is the non-inferiority margin. So you don't want to make a compromise beyond that delta or the margin that you have set as the compromise that you are ready to make. Okay, so this is a non-inferiority design. Now, we also said there's something called as an equivalence study. Now, what's an equivalence study? An equivalence study is to demonstrate that the compared treatments are equal. Okay, it's not non-inferior. You're saying it's equal. So what's the null hypothesis here? The null hypothesis here is that treatment X is either worse or better than treatment Y for a given condition by greater than delta. You know, it's sounding very similar, but it's actually not the same. So it's either worse or better than delta. So what's the alternate hypothesis here? That treatment X is neither worse nor better for a given condition by greater than delta, where delta is the equivalency margin. I'll show you an example here that will make it even clearer. Now, here is an equivalence study. This is the heritage study where a biosimilar trastuzumab was compared to Herceptin. Now, we said a non-inferiority margin is not worse than. Okay, but here you see that there is a margin given on both sides. You know, when you're comparing the hazard ratio, they're saying that as long as it does not exceed 1.24 or go below 0.81, I will call this as equivalence. When it comes to response rate, it's saying minus 15 plus 15 is acceptable to be to me as equivalent. So what does this mean? Let's say you have Herceptin, which produces a response rate of 50%. Now, if you want to say that the biosimilar Herceptin is equivalent to Herceptin, then you could have anywhere between a response rate of 35% to 65%, which will be accepted as equivalent. So you have a margin given on both sides here. For non-inferiority, you will have only one margin of non-inferiority that is given, and that's what we will talk through the rest of our lecture today. So I'm going back to the topic. Non-inferiority trials in oncology is as good enough means the topic should be on equivalence studies, not on non-inferiority. So for today, the topic should actually be non-inferiority in clinical trials in oncology is not worse, good enough. Okay, I hope you realize the subtle difference between equivalence and non-inferiority. If we have time and if we have doubts, we'll probably discuss it a little later. So when do you do a non-inferiority design? Now, this is the standard drug. It's got good effectiveness. It's convenient. It's pricey. It also has side effects. Now, let's look at a new drug that's got a slightly lower effectiveness, but it's more convenient, cheaper, less side effects than the standard drug. So if you have a situation like this, then you are in for a non-inferiority trial that you can design for this intervention. When do you do an equivalence study? You do an equivalence study when you are looking at biosimilars or generics. Okay, when you're looking at biosimilars or generics, you do an equivalence study. But when you're comparing two treatments, one of which is slightly less effective, probably, but more convenient, cheaper, with less side effects, that is when you look at a non-inferiority design. So here the question is, how much worse than the standard is not much worse? And that again is something that is the non-inferiority margin. How much compromise are you ready to make? So that's the non-inferiority margin for the sake of the other advantages that you have with the new treatment that you have at hand now. Okay, so this is how you will interpret a forest plot when you're talking about non-inferiority margin. So this is the point of no difference, that's 0. If your non-inferiority margin is set at 5%, for example, let's say you're talking about response rate, and you're looking at non-inferiority margin of 5%, which means you're ready to take a 5% compromise. What should you look at? You should look at whether the upper limit of the confidence interval is within this margin. So this is 0, this is 5%. Is the upper limit of this confidence interval within that non-inferiority margin? If the answer is yes, then you have a non-inferior option at hand. If it exceeds the non-inferiority margin, which is what it's doing here, that's the lower limit of the confidence interval, it may be 90%, 95%. That's the point estimate. That is the upper limit of this confidence interval. So if it crosses the non-inferiority boundary, okay, this 5% is the margin. This is called the non-inferiority boundary. So if you cross this, then your non-inferiority margin is exceeded. So this is not non-inferior. Now, again, this is very carefully worded. It doesn't say it is inferior or superior. You're not using terms like that. You're saying that this intervention is not non-inferior to the standard treatment against which you have compared this particular option. So that is how you will assess this. Now, the greatest question that everybody asks is, how do you decide on this non-inferiority margin? How do you say, I am ready for this percentage of compromise with this new treatment against the standard of care or the existing treatment? Now, you could set this by 2 ways. One is that you could set it at the lower bound of the confidence interval of the effect of the active control. Sounds very complicated. So don't worry. Let's take this example. So let's say, for example, you have an intervention A that you're comparing against placebo. You've got an intervention B that you're going to compare with A in the non-inferiority study. So what do you need to look at is the confidence interval for A versus placebo, and fix the boundary at the lower limit of this confidence interval for A versus placebo. So that means you're saying that the lower limit of the confidence interval is all that I want this drug to be non-inferior against. Okay, so I'll show you another graph or a picture where this will be even more easy to understand. Or you say that you want to fix the non-inferiority margin as a percentage of the magnitude of benefit that the treatment that you want to compare against. Again, I'll show you this in another picture that will come very soon. Okay, so just keep these two at the back of your minds. Margin or the non-inferiority margin can either be a relative term or an absolute term. So now what's a relative term? When you're comparing with the hazard ratio or a relative risk, it is a relative term. If you're comparing with an absolute difference, for example, response rate, then that is also one way of doing a non-inferiority margin. So relative risk or a hazard ratio, which is relative, or an absolute difference in terms of percentage, which is also something that you can consider. Now, there is a lot of arbitrariness and expert opinions, which is backed by science when you're deciding on a non-inferiority margin. Now, for the same clinical situation, look at the varying non-inferiority margins that one can have. It can range anywhere between 1.15 to 1.53. Now, this is a huge compromise that somebody is ready to make. Well, this is a reasonable compromise that somebody is ready to make. Okay, so remember that since there is a lot of arbitrariness and expert opinion here, there can be a wide margin of non-inferiority for the same clinical situation. This is short versus long trastuzumab for localized breast cancer post-surgery. Okay, so this is how it can be, and so we need to be ready to accept something like this. Okay, so this is a little more crowded and maybe also a little confusing. Now, this is a forest plot that's showing you a lot of point estimates and confidence intervals. Now, I'm going to try and explain to you that when you see a forest plot of a non-inferiority study, how do you decide whether it's inconclusive, whether it's non-inferior, or a little more confusing, which is non-inferior and superior, non-inferior and inferior, because all of these things can happen when you look at forest plots that are there in these non-inferiority studies. So let's start looking at this easily first. I'm showing you three of these hazard ratios that are there, point estimates and confidence intervals, wherein the upper bound of the confidence interval has crossed the non-inferiority boundary. Okay, let me say that again. The upper bound has exceeded or crossed the non-inferiority boundary. Clearly, in these three situations, non-inferiority is either not determined. Why am I saying it's not determined? Because of these wide confidence intervals that you're seeing here. Okay, so then it is not determined. When can this happen? If your non-inferiority study is not powered to prove that non-inferiority margin. So if a situation like this arises, it's either inconclusive because your trial is not properly designed, or non-inferiority is not demonstrated, okay, because the upper bound is crossed. Let's come to the bottom here. Now, the upper bound has crossed the non-inferiority margin, and the lower limit of this confidence interval is more than the point of no difference. Okay, upper bound crossed, lower bound is beyond or higher than the line of no difference. So this is clearly inferior. Okay, so there is some inferiority here. There's inconclusiveness and non-inferiority not being demonstrated. So all of these are there in this. Let's look at the next set of ones. Okay, these are two instances where clearly non-inferiority has been proven. Proven because the upper bound of the confidence interval is lower than the boundary here and here. Your point estimate is straddling 1 or it is less than 1. Okay, so the point estimate is straddling 1 or less than 1. If it's more than 1, if it's still crossing this side, then it's still non-inferiority. So you don't have to be strictly straddling 1 or less than 1. There are instances where you might cross 1, but as long as the upper boundary is within this limit, it is okay to call it non-inferior. Now here comes the problem. You're seeing two instances here where I'm calling this as non-inferior and superior, non-inferior and inferior. Now, how can this happen? It's a little complicated there. Non-inferior and superior can be said in the same study if your trial is also proven or powered to give you superiority in the same study. So you can say this is certainly non-inferior, not only this is non-inferior, this is also superior. So if your study is powered to answer the superiority question also, then it's okay to say in a non-inferiority study that your intervention is superior. Okay, so you have to look at the statistics there to decide whether this result is robust or not. And then finally, this is something that's even more confusing, I would say. Here, the lower limit is beyond the line of no difference. The upper limit is within the non-inferiority boundary. Okay, the upper limit is within the non-inferiority boundary. The lower limit is above the line of no difference. So this is non-inferior. But typically in statistical parlance, you would not call this non-inferior. You will call this as an inferior intervention compared to the standard, because the point estimate is beyond 1, both the lower limit and the upper limit are to the wrong side, which means it's beyond the line of no difference. But can you still call this in a non-inferiority study? The answer is yes. This can happen in two situations. One is if your non-inferiority margin is very wide. For example, the 1.52 I showed you in the previous slide. That can result in a situation like this. The other is when your sample size is really huge and you're making out a small margin of non-inferiority because of huge sample size. Now, this can typically occur in certain meta-analysis. Okay, so typically should not happen, but there are rare instances where you can have a non-inferiority study, but the statistical interpretation might actually be inferiority, but because of certain flaws, the flaws being one, the non-inferiority margin chosen is large, or if your sample size is huge, that it picks up a very small difference, then you can still call this non-inferior in spite of the standard statistical interpretation being inferior. Okay, so this gives you all the possibilities in terms of the forest plot that you can get in a non-inferiority study. The next very important question is, how do we reach an acceptable non-inferiority margin? Remember, I told you this is arbitrariness, expert opinions. Even patients are part of the panel that decides on what is an acceptable non-inferiority margin.
Sandil was 10 minutes.
Yeah, good. I saw the watch. It's 8 o'clock. Done. Okay, so here you have, okay. So what should an ideal non-inferiority trial consist of? Now, if that's the clinical setting, inclusion, exclusion criteria, you should have a test drug or intervention. You should have an active control against which you're having a test drug or the intervention. And it's also very important to have a placebo or the previous standard of care against which this test was compared and it became the standard of care. So this is the previous standard of care. It's not the present standard of care. The present standard of care is this. You're trying to compare the active control. You're trying to control the test drug. This is the new drug that you want to try against the active control. Active control is the present standard of care. This is the previous standard of care. Now, why is it that you need a placebo here, which typically does not happen? I'll tell you why it doesn't happen. You need the placebo or the previous standard of care here because, one, you want to first establish what is the difference between the active control versus previous standard of care. Because only if you know this effect size, you can then fix the non-inferiority margin as a percentage of this effect size. Okay. Now, this is active control, which is the present standard of care. This is the test drug or the intervention, which is the new intervention that you want to compare against the active control. And then you have a placebo or a previous standard of care. Now, only if you know this effect size, you can say that my non-inferiority margin is going to be a percentage of this effect size, which is the compromise that I am ready to take. But this cannot happen. Why is it that this cannot happen? Because it would be non-ethical to have an arm which is either a placebo or the previous standard of care, because that arm is going to be substandard. You cannot ethically put a set of patients on a substandard arm just because you want to have a comparison with the active control and get an effect, because you want to have a percentage of that effect size as your non-inferiority margin. Okay, so the second reason why you have to have this arm, again, hypothetical, is let's say that this is so much inferior to this that it may be even inferior to the previous standard of care or placebo. That could happen. You just don't know. You're trying to say here that I'm accepting a non-inferiority margin here. This is okay. It's a new intervention. But let's at the end of the day say that this is going to be even worse compared to standard of care or placebo. That is not acceptable. So again, two reasons why ideally you should have a previous standard of care or placebo, but which you can't have because of ethical reasons. One is because you want to look at the effect size, The second is you want to make sure that your test drug or intervention is not worse compared to placebo or the previous standard of care. Okay. Now, how do you get this effect size if you can't have this placebo? It is based on what the effect size was in various studies done earlier. That I will show you in the example that I'm going to show you here. Okay. So now this is the IDEA analysis. What did the IDEA do? The IDEA study looked at a set of studies randomizing patients to 3 months versus 6 months of adjuvant therapy, Kpox or Folfox, in adjuvant therapy of colon cancer. Now, this is surgery only. This was the previous standard of care, which is surgery plus 5-FU leucovorin. This is the present standard of care, which is surgery, 5-FU leucovorin plus oxaliplatin, which is the MOSAIC study. This is your new study wherein you're trying to prove the non-inferiority of 3 months to 6 months of therapy. People sat together and decided that an absolute difference or a compromise of 2.7% is acceptable. How did they get to this 2.7%? It's again partly arbitrariness, partly science. What is the science here? The science is here that in many studies which compared 6 months of Folfox to active control, which is 5-FU leucovorin, you had a varying difference stand from 72 to 78%. And this was roughly about 6-7% beyond or better than the standard of care, which is 5-FU leucovorin. Say they took a percentage of this difference between 5-FU leucovorin versus Folfox, which they decided was 2.7%, and then said, this is the absolute difference that I am ready to accept as the non-inferiority margin. Where does this 1.12 come from? When you convert this minus 2.7 or the non-inferiority margin into a hazard ratio, there's a formula to do this. They ended up with a hazard ratio of 1.12. So finally, what did they say? In the IDEA study or the IDEA analysis, they said that if the upper bound of the non-inferiority margin is less than 1.12 for 3 months versus 6 months, then I'm going to consider 3 months as non-inferior to 6 months. Okay, so that is what the IDEA actually decided to prove. Was it fine to do a non-inferiority study here? It was fine to do a non-inferiority study here. The reason being 3 months was going to cost less neuropathy, shorter duration, less hospital visits, lower cost. So it was fine to do a non-inferiority study. These are the non-inferiority curves. The upper bound was 1.15, which is higher than 1.12. So the non-inferiority was not proven. It was not proven for Kpox plus Folfox 3 months versus Folfox Kpox 6 months, that 3 months was non-inferior to 6 months. It was not proven. But what did the forest plot show here? That Folfox 3 months was not non-inferior to Folfox 6 months, but Kpox 3 months was non-inferior to Kpox 6 months. Why are we saying so? You look at the upper bound of the confidence interval here. This is 1.12. This is lesser than that. This is 1.06. Point estimate is to the left of the point of no difference. So we are accepting here that it is non-inferior. So 3 months is non-inferior to 6 months of Kpox, but 3 months of Folfox is non-inferior to 6 months of Folfox. Okay. So we don't have time to go through each one of this, but this is the interesting NCCN guide. You see that for the low risk patients, it's still saying 3 months of Folfox is okay, in spite of us saying that it breached the non-inferiority boundary. So why do we think that still saying that 3 months of Folfox might be enough? It's because of this line here at the bottom. There's a 5-time increase in the incidence of grade 3 or above neuropathy for 6 months Folfox versus 3 months Folfox. And patients may be ready to forego that additional benefit of 6 months of Folfox for the sake of the lower incidence of neuropathy that you're getting with 3 months of Folfox. Okay. So even though your non-inferiority margin has been breached, you're still ready to accept 3 months because some patients might be ready to forego that small additional benefit because the incidence of neuropathy is likely to be lesser with FOLFOX compared to CAPOX. The last example, and then I will wind down. This is, Seema and Sudeep's meta-analysis of 3 months versus 6 months of adjuvant, 3 months, a shorter versus longer trastuzumab in adjuvant breast cancer. Again, justified in doing a non-inferiority study. The reason why I'm showing here is this is kind of a little bit of a confusing, statistic that you get at the end of this study. Okay, so how did they decide on the non-inferiority margin? Remember, I showed you varying non-inferiority margins for this particular study. So here they chose it as a median of all those non-inferiorities. You remember it ranged from anywhere between 1.55 to 1.53. So 1.3 was the median. So that's how they decided on the non-inferiority. Now, this is an individual patient data meta-analysis. You see that finally, the point estimate is 1.14 and the range is 1.03 to 1.25. Remember, statistically, this is actually inferior because the point estimate is 1.14 and the confidence interval 95% is on one side of this point of or line of no difference. Okay, so the statistical or hardcore statistical interpretation of this would be that 3 months is actually inferior or shorter is inferior to longer. But their conclusion was that it was non-inferior, and the reason that they came to that conclusion is what I quoted earlier, because this is a meta-analysis, okay, and they took their non-inferiority boundary as 1.3, large patient population because all the patients had been pooled together. So there is a possibility that because of that reason, you would still be ready to conclude this as non-inferiority, though in the strictest of statistics, this would be termed as inferior because of the kind of range that you're seeing here. Okay, but even more interesting is this. In the same study, in the discussion, you would read that it mentions that if you were to test superiority, then 1 year of trastuzumab administration would result in significantly better DFS. HR is 0.87. So depending on whether you're testing inferiority or superiority, your conclusions might change. This is another meta-analysis which says that the 1 year is superior to a shorter duration of trastuzumab. So, clearly, depending upon your sample size, depending upon your margins, what you're trying to test, with the same numbers, you can come to 2 different conclusions, and that is what non-inferiority or statistics is all about. So I will summarize here. The questions that you need to ask are, is a non-inferiority trial appropriate? How did they arrive at the non-inferiority margin? Is there some justification for that? You could use either the absolute difference, which I said, the 5% difference, for example, in response rate, or a relative difference, which can be a hazard ratio, or a relative risk difference that you can use to define a non-inferiority margin. Non-inferiority ideally should not be interpreted as superior or inferior, though there may be some situations where the situation might arise. And an appropriate control and adequate reporting is extremely important when you're considering non-inferiority studies. So I hope it was not very confusing. I wish we had a lot of time to discuss each one of these in detail, but unfortunately we don't have, but that's fine. I will stop here. And if there are any questions and Shahu would permit, then
we can take 2 questions.
2 questions. Okay, Amol is there. Amol, go ahead.
Hi, sir. Hi, sir. So I just wanted to ask that if you have to design a non-inferiority trial in an early breast cancer for maintenance trastuzumab, what will be your non-inferiority margin? Will it be 1.15, 1.3, 1.4?
1.15.
1.15. And for the standard trial in esophagus, surgery versus no surgery, it was 1.3 was the margin they have taken. Will you be comfortable, or again in adjuvant and all you will be comfortable with 1.15?
I think generally 1.15, 1.2 is what I would think would be reasonable in a curative setting, because we wouldn't be ready to make a big time compromise when it is curative.
So basically, now I got the answer. If it is not 1.15 or 1.2, you will not give much weightage to that study.
Unless the advantages of
In an
that new
adjuvant setting.
Yeah,
In an
unless the
adjuvant.
advantages of the adjuvant setting that you're talking about are huge. When I say advantage, I'm talking about the cost or the duration or the adverse event profile. Let's say is superb compared to the existing intervention that is there. Then I may be ready to make that compromise. I told you the example of 6 months of FOLFOX versus 3 months of FOLFOX. Why would I accept it? A 5 times 3 versus 16% increase in grade 3 neuropathy is a little troublesome. So I would not want to go with 6 months of FOLFOX, even though that might give me a slightly better margin in terms of the benefit. So if the toxicity is huge in terms of the difference, the cost is huge, I may be ready to make that slightly more compromise. But in general, if you want me to give you a number, I think 1.15 to 1.2 would be reasonable.
Thank you, sir. Thank you.
Prabhat.
Prabhat, you're
Sir,
asking one?
yes, sir.
Yeah, please. Last one. Yeah.
So can we do a single arm non-inferiority trial, considering all the trastuzumab discussion that is going on? If we only have to hypothesize to begin with.
So I think there is a a study design wherein people are saying that you just take 2 patients at a time and then give this one patient X intervention and the other patient Y intervention, and then you compare these in pairs rather than doing a randomized study. It seems to be a better way of doing a non-inferiority study, though I didn't get into the details of how more robust would it be compared to doing the classic non-inferiority study. But if you're just doing a one-arm study, that's what it looks to be, that one patient X intervention, the other patient Y intervention, X intervention. It's not very different from a randomization, but there seems to be a subtle difference in the way that you choose patients for one intervention compared to the other. So it seems to be possible, but I'm not too sure that I have clearly understood how that should be done. So I'm not very clear about that, but it seems to be possible.
So I'll stop here in view of the
Thanks.
because thank you, Dr. Sendil. But if all people agree, and we can really have a part 2 of this exact thing in next 10 to 15 days. Dr. Sendil has slide prepared. Probably we can have more example based and have a 45-minute session just for the statistics, non-inferiority. This is actually, as it rightly told, the science is little less, more of a consensus things comes in. It's a mixture of both actually. You don't have solid science actually in non-inferiority, and few very salient points were put out, and especially the CI thing. The confidence interval is so very important, and people need to look into these details. And sometimes we have an inferiority margin of 1.53 also. There are a lot of trials which look into that, and actually you have 50% worse treatment and still it is non-inferior as a conclusion. So we need to look into this very, very carefully. So if all people agree, maybe in 3 weeks, I can request Dr. Sendil.
I'm happy to do it. Maybe we can do it in a better fashion, slower and better.
So we can do it maybe for a prolonged interactive section. So thank you, Dr. Sendil, and please answer the chat questions and Q&A while we take on the next panel. So Dr. Amol, we will be having you as the moderator, which will be for early HER2 positive EBC. You are starting 10 minutes late, so you will have 10 minutes more for your time. So you will finish at 35 minutes. Okay, thank you.
I always love more time, but if my screen is visible, I hope.
Yeah, it is visible. You can make it full screen and invite your panelist.
Okay.
Or do you want me to invite?
Full screen? I will invite. Is it now visible? Full screen? Is my screen visible? Full screens?
No, sir.
No, sir.
No.
Oh God, I hate this.
So can you close it, stop sharing, and go make it full screen, and then start sharing actually.
Okay, let me again. Okay. No. Share. Is it now visible?
Yeah, it's again not full screen.
Yeah,
so,
I'm not able to do it.
So Amol, what you do is stop the share, make your slide full screen, in your computer, and then go to share.
It is full screen.
Sir, you click the button there, the cup button. Once you share, you click that cup button.
Okay, can you see now?
So that.
Okay. Now is it visible? It should be visible, right? It is full
It
screen
is
to
not
me.
full screen, sir.
No, sir.
Just click that cup button, sir.
And I have done that. It is full screen to
But
me.
no, sir. It's not full screen to us.
Well, I have this problem with my thing. So what you do is stop share,
I have done stop sharing.
and then when you share, you click on that full screen image on your computer. Don't click on that half screen. Reshare and click on that full screen. You will have that in your computer when you have that option. Go to share and go to the full screen in that directly.
Okay. Yeah, I'm very sorry, but
अरे डॉक्टर मोल का ऑफिशियल टाई अप सर ट्विटर के साथ है, जूम के साथ नहीं है.
नहीं है, बिल्कुल नहीं है. Anyways, can you see the small screen, yaar?
Yeah, you can see the small screen.
You
So
can
you
go
can
ahead,
start
sir.
your
You
panel
can go ahead.
discussion, Amol.
Yeah, please. So let me invite my panelists. I hope the slides are visible. And let me invite Dr. Prabhat, Dr. Seema, Dr. Ashish, and Dr. Bala. I assume all of them are here. And this is a Zoom discussion where, unfortunately, I'm able to only see the screen. Are my slides moving?
No.
Are the slides moving?
Yes.
Yeah, it is moving. They are moving. They are
Okay,
moving.
fantastic. So I have no conflict of interest. Slides are taken from ASCO and ESMO for discussion purpose.
So
Amol,
we will complete your thing at 8:55.
Okay, thank you.
Yeah.
So how much can we de-escalate in treatment for early stage HER2 positive EPC? And the theme is, can we omit carboplatin? Can we reduce the number of cycles from 4 instead of 6? Can we omit taxanes, which probably we may not discuss because it's an older trial? Can we omit pertuzumab in adjuvant therapy? So let us start with adjuvant first. And of course, we have an affinity update, which was given in ESMO breast 1 month back. And it is 11.5 year affinity update. So if you see this slide, you can see that primary endpoint, IDFS, affinity definition differs from STEEP definition. Can everybody see this? All my panelists can see this, right? So let me ask Dr. Prabhat, do you know what is the difference in the affinity definition of IDFS from the STEEP definition and how it's going to affect the interpretation of the trial? Any idea?
No, sir, not exactly right now. Exact difference, I don't remember.
Dr. Ashish?
I'm not sure, but I'm not sure if the contralateral DCIS sometimes they include. Sometimes they insist it has to be an invasive carcinoma only to be an endpoint.
No, I think that was not the difference. Anyone else? Dr. Bala, Dr. Seema, any idea? What is the difference in the IDFS definition of affinity versus the STEEP definition, which is the JCO population 2007, which most of the trials use? Dr. Seema, any idea?
Maybe all contralateral cancers were not included, irrespective whether they were DCIS or invasive.
Okay, so for the benefit of the audience, I have made this slide just to tell what is the difference in the affinity trial, IDFS definition, and STEEP criteria. The difference was the death from any cause was included in affinity, but in STEEP definition, only if it is due to breast cancer and unknown. That means we don't know why the patient died, it was included. Affinity included all events. That means death from any cause. Rest of the thing was safe. And please read the note. I will read out for the benefit of everybody. The broader IDFS definition and affinity, including all-cause death, increases event counts. This may reduce the apparent magnitude of benefit versus a narrower STEEP definition, affecting the hazard ratios and statistical significance. That means technically what they're saying is that IDFS definition in affinity is broader, hence the magnitude of benefit if they have used the STEEP criteria would have been different, and hence when you look at the magnitude of benefit in affinity for IDFS, as we all know that there is the only benefit of IDFS, there is no OS benefit, we have to keep this in back of our mind, because if you are a pure statistician, this is something that you should keep in back of your mind. And Dr. Sahu has last time told me that I don't include statistics in my talk, so I had put this particular slide so that everybody appreciates.
But then this looks better.
So of course, the idea, the affinity IDFS is of course better because it is stringent. They have included everybody, so this is better. Yes. So that is a plus point for the trial rather than a negative point. So in spite of a stringent definition, that means they have included everybody, all deaths, they still have this much IDFS benefit. And we all know the benefit is increasing over the years. And this was the final results of 11.3 years. What is important is, and that is everybody has discussed, is there is no OS benefit in intent to treat population. And if they divided by the nodal status, the node negative did not have any benefit. Node positive, of course, have some benefit for the OS. Now, there was a very interesting thing which was discussed in the ESMO when this particular slide was discussed. And it was, I will read out for everybody. It is my desire and recommendation that in EBC studies, the primary endpoint should be distant disease-free survival, and we should not wait for OS data to mature before making drug approval decisions. Delaying approval may result in patients progressing to metastatic disease and dying as a consequence. So let me start with my panelist, Dr. Prabhat. Do you agree with this, that in early breast cancer, IDFS should be, or as he has said, distant disease-free survival should be primary endpoint and should be considered for drug approval, and we should not bother about the OS or would not wait about the OS for drug approval? Dr. Prabhat, your thoughts on this particular statement?
Sir, I agree that the disease-free survival should also be an approval. At least we can use it if patient is paying out of money. If FDA should approve, and whether UK NHS should approve or not, that is a controversial that they can look after. But FDA can approve.
No, we are talking about
remaining
FDA.
disease-free. Remaining disease-free is also equally
we
important.
follow that in India.
Remaining disease-free is also equally important. Yes, sir.
Okay, you will be happy with distant disease-free survival, and you will not wait for the OS. Anybody else?
Because OS will mature after 10 years in breast cancer trials, except for TNBCs.
So I'll come to counter argument, but let us understand everybody's opinion. Dr. Ashish.
Yeah. So at least if DDFS is given importance, at least we are still improving on as compared to STEEP criteria, because a local recurrence or a DCIS, that doesn't kill the patient. Now, number two, as Dr. Chirag also pointed out in the chat, distance metastasis is probably a better surrogate endpoint for aggressive biology, say triple negative or a HER2 positive, because it's very uncommon that we are going to cure patients once if you have a metastatic triple negative, or like HER2 positive, the story may be changing, but it may be more relevant. But for an ER positive, again, for a younger patient, yes, but for patients in their 60s and 70s, because especially now with so many other options when they become metastatic. So, I'm not very sure if ER positive, we have enough.
So you will not use it as a blanket. You will use it as per the subtype of the breast cancer.
Yeah, mainly because these drugs are so expensive. If they were coming at a cheap price, then that's a different story altogether. So the number needed to treat, say for a ribociclib, is huge. And in terms of the policy, for the policymakers, it's huge spending. So that's something which we have to be careful about.
Okay. What about Dr. Bala? What's your opinion? And then we'll ask Dr. Seema.
Yeah, same, sir. I too agree with the same opinion.
So that means you are not, you will vary from subtype to subtype, but you will not have a blanketly the way Dr. Prabhat was saying.
Yes, sir.
Dr. Seema, what's your take?
Seema is left for the emergency, I think. So you have to carry on with the three other.
Okay, fine. So the question comes, now that you have agreed that you will not wait for the OS and you will be happy with DDFS, most of you agreed, and with some subtle differences. The next question is that, of course, we need to ask first these, that will you use pertuzumab for node negative patients in adjuvant with this particular data, Dr. Prabhat?
No, sir.
So we will not use. Anybody else which disagrees? Dr. Ashish, Dr. Bala, anybody?
No, sir, I don't use.
So you will not use for node negative?
Yes.
Dr. Ashish?
Yes, so I think if the patient is going to receive the entire chemotherapy, then probably we don't need pertuzumab for node negative. But I think in the West now the field is moving towards using pertuzumab backbone to de-escalate some chemotherapy.
Okay. So you will not for a large users and node negative. So the next question comes is that now that you're saying that approval should be given on DDFS, not wait for OS, but now that OS is not seen and you will not use, will you consider, or do you think that FDA should consider to withdraw that approval for the node negative patients? Or they should have done it way back, because 8.5-year follow-up also was not showing OS difference. So Dr. Prabhat, do you think that the other way around, that means now OS is not seen in node negative, should the approval be withdrawn for the node negative in adjuvant setting for pertuzumab? I agree that approval should be given, but now that it is given and the data is seen that it is not useful, it should be withdrawn. Am I audible?
Problem here, Dr. Amol, maybe that we are now, I mean, usually withdrawals are very difficult unless they're causing harm. And second thing is they will say
it is causing harm. If you see the confidence interval for node negative, it is crossing unity. It is going to 1.3.
But by harm I meant like say PARP inhibitors were withdrawal in ovarian cancer because they were causing more deaths. So here at least there's no benefit, but not so much harm. And also, I mean, I don't think we should worry about what the US is doing. We should just decide on our own.
See, we have a lot of residents.
Ideally speaking, we shouldn't be in this situation. I mean, why couldn't they just do a smaller trial with only high-risk population rather than doing a huge trial and include everyone? So these are commercial decisions which a company takes when they design their trials.
Okay. So moving on, now let us have a more clinically relevant decision. Now we have seen that the benefit is there in node positive, but they have not distinguished between whether 1 to 2 nodes or more than 4 nodes. So Dr. Prabhat, what's your take on, suppose the patient is only 1 node positive and you don't have the subset analysis, will you still use pertuzumab in adjuvant? Node negative, no. What about 1 node positive?
Looking at the previous data for 1 node, I will not. This 11-year update alone, if you would have given to me, then maybe I would have used. But I know that previous data says more than 4 node, it is more. There is good difference between the two arms. So more than 4 nodes, I will definitely use.
So that means more than 4 nodes you will use. But what about 1 to 3 nodes? Suppose patient has 2 nodes. You will use or you will not use?
No.
You will not use. Okay. What about Dr. Bala? You will use it for 2 nodes?
Yes, sir.
You will use.
Yes.
So you're not worried whether the magnitude of benefit is less for 1 node or 2 nodes, and more than 4 nodes is more. You're not worried about that.
At least for node positive, I will inform the benefit of the patient and will make a shared decision. But we'll definitely try to inform the patient about the data available to the patient.
So you will discuss. Dr. Ashish, what's your take for 2 node positive?
So I think in my center, actually, most patients we moved towards neoadjuvant. And
I understand. But suppose the patient has come to you after surgery from outside and has 2 nodes only. What you will do in your setup in India? Patient says, if you want to, if you say, I will arrange. Otherwise, if you say, I will not arrange.
Yeah, so that's a difficult situation. So if I have to follow the book, I would definitely discuss affinity. But sometimes I wonder in these patients, how do we know that they're not going to benefit from, say, TDM1, where we have an OS benefit with TDM1 and no OS benefit with pertuzumab at all? Just because we've not given the neoadjuvant, we'll never know. We never know whether,
So basically, what the take-home message that I wanted to give to the residents who are listening is that the magnitude of benefit in node positive is definitely lesser for 1 to 3 group of nodes. We have to discuss the data, and ideally we should not be in this situation because most of these patients should receive neoadjuvant therapy. But if they're not received, they'll come to you, and then you should discuss with them that the magnitude of benefit for those 1 to 3 nodes is less as compared to more than 4 nodes. Now, last question about this affinity. What about the duration? We talk about the reduced duration of trastuzumab. What about the reduced duration of pertuzumab? Dr. Prabhat, will you like to give only 6 months of pertuzumab, or will you like to go for entire 1 year?
Due to lack of data, no comment, sir. If patient is not affording, then
this is an individual situation. This is an expert discussion. This is deep dive. Patient is sitting in front of you. What you will tell him? Patient says, if you say I will arrange, if you say I will not arrange, I am borderline finances.
Given the borderline difference between 1 to 3 node, maybe 6 months of pertuzumab is also good enough if patient wants to do everything and in that case, but more than 4 nodes, maybe I will give complete 1 year.
So you're saying for more than 4 nodes, you will give for 1 year, less than 4 nodes, you will probably go for 6 months. Dr. Bala, any other take on lesser duration? Trastuzumab we can give as low as 3 months. So why not pertuzumab for as low as 3 months or say 1 node positive?
Sir,
Amol, you have stopped sharing?
right away from the
No,
start.
I'm not stopped sharing. Are my slides not visible? Sorry.
No, sir.
You can do that while Bala answers your question.
Sir, straight away, right from the day one discussion will be if I'm going to do pertuzumab, it is for the as per the trial. If I'm not going to do it, none, all or none. At least for the pertuzumab sake, I'm not doing the shorter durations of the pertuzumab.
Okay. Are my slides again visible?
Visible, sir. Now.
Yes. So to conclude, for audience, the benefit of adjuvant pertuzumab is not there in node negative, and we should not encourage patients to take that. For node positive, benefit is there if the patient has borderline finances. For lesser node positive, that means 1 to 3, you can discuss and have a shared decision with the patient. Tell them that the magnitude of benefit is less, and maybe we can offer a shorter duration if the finances are an issue. So now moving on for neoadjuvant therapy. So let me ask, do you give NSAT for all your patients, Dr. Prabhat, or there are some patients in which you let surgeon operate upfront? We are talking about HER2 positive EBC. Prabhat.
Sir, we are running a trial. So in trial setting, we are randomizing node negative patients to
No, I'm
upfront
talking
surgery
about
versus
outside
NSAT.
trial. I'm talking about outside trial. Patient comes to you tomorrow morning. What are those patients in which you will let surgeon operate based upon the size, node presence, or for all patients you go for NSAT?
More than 2 centimeters, I would like to go ahead with NSAT first.
So you will have a cutoff of 2 centimeter with node positive clinically or node negative?
Any nodes.
So 1.9 centimeter with 1 node positive, 1 node palpable. What will you do?
Any node positive will go for NSAT.
Okay, so less than
proven.
2 centimeters.
FNAC proven.
Okay.
FNAC proven. Yes.
Okay. So I will modify it. So according to you, less than 2 centimeter clinically and investigation wise, node negative, you will go for upfront surgery, right?
Yeah. Yes, sir.
Okay. Anybody else has different thing, Dr. Bala?
No, sir. Same.
Or you will give NSAT for everybody?
No. Less than 2
centimeter.
T1
less than 2
is surgery, rest all neoadjuvant.
Okay. And Dr. Ashish, same or different?
Yeah, same, but sometimes due to logistics issue, you may not have dates for surgery immediately. So, but what we do there is like, if you have a tumor which is still fitting into the APT trial inclusion criteria, like node negative, maybe up to 3 centimeter. So I don't give the anthracycline. I would just probably, even if I have to give a neoadjuvant, I'll probably give just weekly Paclitaxel and Trastu and then get them to surgery.
Okay. So that is the next question. Suppose you decide to go for NSAT for more than 2 centimeter and has clinical node positive, which regimen you use? Dr. Prabhat, TCHP or TCH or what? Finance is not an issue.
Sir, we go with AC and THP, node positive.
AC followed by THP. You don't for T. So you don't use carboplatin. You don't give TCHP.
No.
Any particular reason?
Because of the old trial also, TCHP had only shown non-inferiority, and that was not for non-inferiority. It was for cardiac, not comparing directly end-to-end DFS. Even for DFS, it is only showing 1% difference, and that too, in fact, AC is still 1% superior in previous trials. And now that we know that carboplatin is useless drug after 2 trials back-to-back in HER2. So all the more reason that AC and THP. Third reason would be more than 4 taxanes definitely becomes a problem for the patient, especially paclitaxel.
What about suppose the patient is not affording pertuzumab then?
Then also ACTH stands standard.
So in that situation, also you will not give carboplatin?
No. All the more reason if ERPR is positive.
No, I'm talking about ERPR positive. Fine. So what about Dr. Bala? What is your go-to regimen? TCHP or AC followed by TCH or AC followed by any other thing that you do in your practice?
It all depends upon the patient. If patient is very young, definitely TCHP. See, because in my setup, so what I have observed.
What is your definition of very young?
Sir?
What is the definition of very young? Less than 30, less than 40?
No.
less than
If
50?
when I see the patient, I presume that she is able to tolerate. So docetaxel and carboplatin at the doses which are recommended in the TCHP, I'll go ahead with it. Otherwise, ACTHP.
ACTHP. Dr. Ashish, what's your take for T2, N2, and you have decided to go for NSAT?
Yeah, so I think I try to start with a taxane and anti-HER2 therapy before anthracycline, and I try to keep my schedule dose dense. So therefore, TCH we've never favored mainly because it's too toxic and it's not dose dense. So either weekly or bi-weekly taxanes, and even and the same even in the Helen 06 trial which Prabhat was mentioning, it was compared directly to TCH. So I don't know whether it's the weekly Paclitaxel which makes much. We know from various meta-analysis that even in HER2 positive breast cancer, dose density matters. So for that reason, for me, it's either weekly, but many times patients may not want to come weekly, so at least bi-weekly, and 12 weeks of Paclitaxel with a single anti-HER2 or dual anti-HER2, and then the anthracyclines come. Then the 4EC comes.
So none of the patients you will use carboplatin. None of the patients.
Not exactly. So my TCH, actually, if I have to use TCH, it used to be docetaxel. So carboplatin is too toxic.
Okay,
Especially
so basically,
even at AUC5.
basically you are saying that in none of the patients you use carboplatin.
No.
Okay, and the same thing for Prabhat and Bala, you're not anyways using carboplatin for none of the patients, or some patients you will use?
No, sir. I already told you. So if the patient is able to tolerate a combination of docetaxel carboplatin, TCHP will be my first choice.
So you are going for carboplatin.
But myelosuppression in thrombocytopenia, but otherwise ACTHP.
And Prabhat?
TCHP.
So
Okay,
no carboplatin. I started 2 patients on Helen 006, but it was dreaded after 4 cycles. Really, neuropathy was troubling them.
Okay, so moving on, see, data from carboplatin in HER2 positive EBC came from this old trial, and this established TCH in curative setting, but the benefit was more for lymph nodes more than 4, that means higher tumor burden. Then there's another smaller trial in which, of course, not smaller, 263 patients, but it was, of course, not in adjuvant setting, in metastatic. They compared TCH with TH, and there was no difference. And this is what is a very interesting thing, that aim of NSAID is to get maximum PCR. And this is a nice slide to show what is the PCR that we have achieved so far with various regimens. And based upon this particular trial was planned, that is NeoCAR HP, in which they have taken patients above 18 with stage 2, stage 3, and they randomize between 6 cycle of THP versus 6 cycle of TCHP, where C was carboplatin. Note that the taxanes was 3 weekly, and these are the inclusion criteria. Most of the patients, 81% were T1, T2, most of them were stage 2. And what they found is that the PCR rates is more or less same, whether you use carboplatin or don't use carboplatin. And especially, irrespective of ER positive, ER negative, the rates are same in both the situations. And if you put these results in context, what they've shown is that even if you exclude carboplatin, your PCR is not going to much affect, and you will get more or less similar PCR as compared to the other comparative studies. So now at the end of this trial, that data you're seeing, Bala, you were favoring carboplatin. So do you think now you will be more comfortable to omit that, or you're not happy with this data? Because you're the only one who was probably giving carboplatin, the patient was fit.
As of now, data seems promising, sir, but I may not be omitting carboplatin as of today based upon this data.
So you will not be omitting, not even for, say, stage 2 patients? Because if you see, the PCR rates are reasonable, you're getting 66%.
Possibly, if they are affording for the dual HER2, I may be.
They are affording.
We can omit. Then we may consider omitting it, at least for stage 2.
Okay. Anybody else has any different conclusions? Dr. Prabhat? For some patients you used to use, so.
Now omitting carboplatin, yeah.
So you will be omitting carboplatin. Anyway,
yes,
now with more confidence, now that you are randomized.
Yes.
Okay. So let us see, the author's conclusion was this, and this is, of course, I've taken from the original. And what they are saying is, yes, with these caveats, but only 1/4 of patients had stage 3 disease will still use TCHP in stage 3 unless long-term outcomes are similar, because we only have the PCR data, we don't have EFS, DFS, and OS data. Insufficient evidence to support 3-weekly nab-paclitaxel or 3-weekly paclitaxel, would recommend weekly paclitaxel or 3-weekly docetaxel, and we'll await for the biomarker data. Dr. Ashish, do you agree with this conclusion from the author?
Yes, I think
Or the discussant?
their main concerns is that is paclitaxel enough chemotherapy, and because in the West they don't like to use anthracyclines, number one. So I think so, especially in stage 3. I mean, if your patient has deep pockets and you're going to go on an ADC, and maybe in the future newer ADCs, that's a different scenario. But yeah, of course, all of us would be worried if it's a T4N2, and especially the PAT-CR, you said 60% is all comers, but in these stage 3 and bulky, sometimes it may be just 30 or 40%. So in that situation, I would probably use Anthra. See, carboplatin, I don't know, first of all, why it was there in BCIRG 006. So even if that BCIRG 006, if you see the long-term data, it was not designed, so that still the carboplatin curve was actually slightly inferior to the anthracycline.
Yes.
Yeah, so in terms of disease activity, especially in a stage 3, why would you omit anthracycline? You can omit anthracycline for an earlier stage tumor, but for a stage 3 and locally advanced, I would probably not.
So basically, the conclusion of the authors is, of course, they wanted to wait for EFS, DFS, OS data, and for stage 3, they will still give carboplatin. But as Dr. Ashish has said, that probably they don't like anthracyclines much. We tend to use that. But let me go forward and ask further question. Are there some patients, Dr. Prabhat, in which you will omit taxanes also and only give double anti-HER2 drugs?
I'm not confident at present, sir. Only when patient is very very frail.
You don't like Fergan? You don't like Fergan?
No, sir. Only when patient is very frail and not fit for surgery at present needs optimization. And even I am scared of chemotherapy. Maybe those patients, VRPR negative, there we can try.
So you will omit carboplatin, but you will never omit taxanes unless you are scared.
Yeah.
That's what you're saying.
Very frail patient where patient is not fit for upfront surgery also.
Dr. Bala, do you get ever scared for giving taxanes?
No, sir. No, sir. At least I'm comfortable in giving weekly taxane. No issues with that.
So you will not omit taxanes at all in any of the patients with early breast cancer HER2 positive.
Possibly not, sir. Possibly not.
Not in 2.1 centimeter tumor also with node negative. You will give taxanes. You will not go with only HP.
No, sir. I will give you taxane.
Dr. Ashish, you are the boldest one. Will you omit taxanes in some patients?
Taxanes, then what will I give? I mean, see, we do have patients.
Only HP. Only HP. Double anti-HER2.
No, that has to be very early tumor, and then maybe if I can give some endocrine therapy along.
I'm telling you, it is 2.1 centimeter tumor node negative.
And ER negative.
Yes.
No, I would at least add a capecitabine or something, but I would not have it. So you're saying chemo-free regimen? That's very difficult. Okay.
So as of now, none of our panelists are bold enough or they are ready to omit the entire chemotherapy entirely. Some of the chemotherapy will be given, and we will discuss that in the conclusion thing. Now, I think we have 7 more minutes. So we will go with the next abstract, and this is the last abstract. Here they try to discuss the question of 4 cycles versus 6 cycles. So let me ask, as of now, anyone giving only 4 cycles of NECT? Dr. Prabhat?
No, sir. 6 cycles or 8 cycles.
6 cycles. Bala?
6 cycles, sir.
6 cycles. Dr. Ashish, of course, will not give 4. Are you giving anybody 4 cycles?
No, we're doing 6 cycles.
Okay. So let us see what this trial. Okay, what is this trial has done? So this trial, they are given THP 4 cycles in stage 2, stage 3A, EBC. They have large number of patients to be included. We'll just go through the slides for running out of time. And they tried to analyze the data based upon HER2-DX also. And what is that? They have taken almost 2,141 patients who at least received 1 dose of THP and 2,028, large number of patients they had underwent surgery. And this is the median age. Most of them were relatively younger. Most of them were stage 2A, clinical stage T2. Node positive were 46%. And this was the baseline tumor characteristics. And of course, they did HER2-DX. So just for the benefit of the audience, what is HER2-DX? It is a HER2-DX PCR likelihood score. It has 27 genes. It is same like Oncotype DX, but only for HER2 positive patients. And there are various publications. Most of them are retrospective, and there are few important publications which I will like the audience to go through. But this is the trial results. And the trial results, what they've shown is that in ER negative, HER2 positive, they got 63.7% of PCR rates. Again, you remember the PCR rate table, 66% PCR rate with 4 cycles. You should be happy because that is the number that we are happy. All patients got 43%. ER positive, HER2 positive, it was 32.5%. They tried to correlate with HER2-DX, and what they found out that those who have HER2-DX high score, the PCR rates were higher, and those with a low score of HER2-DX PCR rates were lower, and it was correlated well. So the conclusion of the authors was this, that in certain patients like ER0 or ER less than 70%, HER2 IHC 3+, we are giving weekly paclitaxel, probably 4 cycles are good enough, especially you have a high HER2-DX. That means probability of anti-HER2 drugs working is high. So do you agree with this conclusion? And suppose you have HER2-DX test available, it is right now not available, and it comes very high, Dr. Prabhat, will you be able to give only 4 cycles?
No, sir.
No?
Not
So
at present.
you want more data?
Yes.
What kind of data you want? Because you will not have a prospective data like Oncotype DX with say 5,000 patients. That way. So in the previous discussion, you were okay for DDFS, but now you want more data. Why is it that, Dr. Prabhat?
No, it is not 100% that high score, a cutoff of more than XYZ predicts 100% PAT-CR. It only says there will be high chances of PAT-CR. It will not say 100%.
But you are getting a good enough PAT-CR of 66%, which is all the other trials are getting. And if you can omit 2 cycles, the toxicity will be less. So are you not tempted?
No, sir. Not at present. 60%, 66% prediction is not too good.
So you want a larger data for this?
Yes.
Okay. What about Dr. Bala? Are you okay with this data? HER2-DX is available, or you get a very high-fi patient who get it done from US and comes to you that HER2-DX score is high. Now he's saying, doctor, give me only 4 cycles. I don't want 6 cycles. What will you do?
No, sir. As of now, I'll give 6 cycles.
Dr. Ashish?
So this HER2-DX is an interesting test. I think this is developed by this Dr. Alex Pratt. I think he works in Barcelona. So I feel a lot of these ER positive and HER2 positive, what you can call triple positives, some of them, even though they're HER2 positive, they don't behave like HER2 positive. And this HER2-DX can actually be used to fish out these, and that's why the PCR rate is only 33%. So,
yes.
If your tumor is really HER2 driven, if your HER2-DX is positive, the tumor is really HER2 driven, then maybe the 4 cycles will be enough to give us a PAT-CR. And in overall, so what I think we should probably pull out from this data, I don't know, I haven't seen this paper, that of all patients who are HER2-DX positive, what is the PAT-CR rate in that? I'm sure that will be much higher than 66% even. So therefore, this is just a biomarker which is telling you the truly HER2-driven tumors, and in them maybe we may be able to de-escalate. But I really don't know. This will be an interesting paper once it comes out.
So we'd like to see the full paper, and if that full paper convinces you and the patient can afford HER2-DX test, you will consider discussing the data and maybe de-escalation.
Correct. So I think in the last few years, even this ASCO, there are some interesting papers coming with ER positive and HER2 positive. People are adding CDK4/6 with TDM1. So and TDM1 is working, and the CDK4/6 is working there. So in terms of so why is it working? So there are some of these tumors which are probably luminal like, and we'll probably have better tests.
Okay, so author's conclusion was the same, that for stage 1, maybe for stage 2, he may consider for 4 cycles. That is the discussant's conclusion, but not for everybody, and we like to wait for larger data. So I think we are running out of the time. So let me have a final slide, which is the take-home slide, which of course I've taken from the ASCO discussion. can we omit carboplatin from standard neoadjuvant therapy? Yes, they say that for stage 1 or 2 diseases, but we like to use only weekly paclitaxel, and long-term outcomes and biomarker data awaited. Is 4 cycles of treatment sufficient? That is THP, yes, for stage 1, stage 2 disease. We are not yet convinced with that because, of course, we don't have HER2-DX test available with us, and we, of course, like to see a larger data. Is it possible to omit standard chemotherapy for some patients? Everybody in the panel says no, and everybody in the ASCO also agreed that not quite yet until we have validated way to select those patients. And can biomarkers be used to right size therapy? Yes, we are getting really close, but again, affordability is an issue in India. Our uptake of Oncotype DX itself is not good, and of course there is a criticism that a lot of patients, there are no Indian data of Oncotype DX. The same thing probably happened with HER2-DX, but probably the test will sooner or later arrive in India, and I'm sure precision oncologists will like to use the test, and probably we should know how to interpret the test. So I think that is my last slide, and I'm finishing on time, Dr. Sadu.
Thank you. Just two things. We had very good presentations. Randeep, remember, me and Randeep actually co-moderated it in the year-end review. Prabhat was there. So can we integrate this HER2-DX, which looks very interesting, that fallacies are there, the retrospective nature and everything, all what was spoken. If there is a radiology attached to that, and there has been studies, although phase 2, based on de-escalation of treatment, based on radiological assessment. And after 2 cycles, they did assess, and based on the PET scan and the other radiology, they did want to de-escalate or escalate the therapy. So if someone has a HER2-DX favorable for a response and has the radiology integrated to it, and the radiology also matches, I'll ask this to Prabhat especially, would you think of putting forward and de-escalating the number of cycles then?
But till now, both the studies that I know, MRI and PET CT, they are not able to predict up to the mark.
Yeah.
Both studies. So
So
MRI and PET
integrating
is
both
out.
of them. I want to speak of integrating the HER2-DX.
Agreed. But MRI and PET both are not able to predict. Only all three are immature. Taking use of all three, you want to say, that also I doubt whether they will be able to predict.
That's okay.
So my point here, Dr. Sahu, is that unless we have very particular PET scan which tracks the HER2 positive disease, I think we have for ER positive, I guess.
No,
so
for HER2 positive also, I think they are looking at the PET scan, which even Ashish spoke about. They're looking at disease which are looking only at HER2 positive. We did listen in last Best of ASCO in Bhubaneswar, and we saw the experts speak about it. That yes, even in metastatic disease, they're looking at these PET scans, and if it is predicting a HER2 positive, actually that it is still persisting, they feel that HER2 therapy does benefit more. So I think we are moving towards that. I think we are not yet there. That is very clearly coming out. The carboplatin anthracycline issue is still alive, as it was even 2-3 years back. But the consensus which I get looking at the experts is, others may correct me, as Ashish rightly pointed out, in the stage 2, you probably can omit anthra in those patients who are probably concerned and those high-risk patients with cardiomyopathy. But in stage 3, we are not yet there to take out anthra. I think that is something people should go back home, not just keep anthracycline for any stage 3 or high-risk patients.
And the other important point is that this all data is under assumption that the patient can afford dual anti-HER2.
Yeah, I agree.
Most of our patients cannot afford.
So it is a done case. We are talking of only dual HER2 target therapy. So Ashish, this is what you spoke about.
Yeah. Also, I think we shouldn't go overboard by just giving 4 cycles and end up with a lot of residual disease and then telling the patient, now you take 1 year of TDM1.
Now you take 1 year TDM1.
Patient is not going to be happy.
Yeah, agree.
In fact, after a few years, we'll take 1 year of TDXD.
Okay, Amol, I'll stop here. You can answer those 2-3 questions which are still left on Q&A. I have answered most of it when you are in the panel. So please answer those. While thank you, all of you. And I will move on to the last panel discussion. And we have this things up there. Dr. Chirag sir will be taking up for the triple negative operable. And we have a lovely panel. Amol will go on to be in the panel for this one. Yeah, please, sir. Chirag sir.
Yeah. Thank you very much, Sahu, for organizing a wonderful program. And let me go to my slides. The slides are visible, right?
Just make it full screen, sir. Yeah, it is full screen. It is full screen.
Yeah. So in next half an hour or so, I will be discussing about. I have changed the title of the topic a little bit. systemic therapy optimization for operable TNBC. And I have a wonderful panel with Dr. Amol Akhade from Mumbai, Dr. Chetan Deshmukh from Pune, Dr. Nitin Ishas from Bangalore, and Dr. Suman Karan from Delhi. Or I mean, she like to be called from Gurugram and not from Delhi. Before we begin, the treatment of neoadjuvant management, my main discussion will be revolving around the neoadjuvant treatment rather than adjuvant treatment. And when we discuss about neoadjuvant therapy, I think it should not begin or it should not end without discussing immunotherapy. But I will start asking Amol about how many of his patients actually afford uh, immunotherapy in for full 1 year when he treats early triple negative breast cancer.
Around 5 to 10% only.
Great. What about you, Chetan?
About 20%.
Great. Nitin?
I would say again, going by the center we work in, about 30 to 35%.
All right. And how about you, Suman?
Sir, to me, it will be about 20. The patients coming to me is 20 to 25%. To my center, it's about 40 to 45%.
Great. So we can say that 60 to 90% of the patient ultimately end up taking neoadjuvant therapy without immunotherapy. The first question that I will start with is we all give anthracycline and taxane in management of neoadjuvant therapy for triple negative breast cancer. Jepar is giving platinum with bevacizumab, and Brightness is giving platinum with a PARP inhibitor. But Dr. Sudeep's abstract he presented in SABCS 2022, it actually focused on anthracycline and taxane with platinum. So, Amol, will you give platinum in all patients as neoadjuvant therapy?
Definitely yes, because of two reasons. One, those 10% who can afford immunotherapy, the regulatory trial itself has a platinum as a part of it. So yes, I have to give that. And those who cannot afford immunotherapy, I have to anyways give, because that is one of the effective drugs. So if they're not affording pembrolizumab, at least they should take carboplatin. So for all my patients, unless there is a contraindication for platinum, I give platinum in NCT for TNBC.
Right. So for first 5 minutes, we will be assuming that we are not going to give immunotherapy. So without immunotherapy, we will be discussing about platinum or no platinum. So Chetan, TMH abstract shows that platinum is effective in patients less than 50 years of age as compared to patients more than 50 years of age. So will you give platinum for all the patients?
Yes, so far I'm trying to give platinum to all my patients, though at beyond the age of 50, I am facing some difficulties giving the TMH regime, which is 100 per meter square of paclitaxel and carboplatin AUC of 2. Sometimes I have to reduce the paclitaxel to 80 per meter square and carboplatin AUC of 1.5. But right now, for triple negative, I'm not very far away from Amol's estimate. I'm just 20% of my patients. So for majority of my patients, I end up using carboplatin because they are not going to afford immunotherapy.
Right. So Nitin, this was the presentation made in ASCO this year, Energy BR 003, and it raises the question about the efficacy of carboplatin in adjuvant chemotherapy. It's not the neoadjuvant chemotherapy. So will you extrapolate from neoadjuvant to adjuvant, or for adjuvant also you will give a platinum?
No. No, sir, definitely not in the adjuvant setting. One trial which had come in 2021, the ECOG trial, which looked at platinum versus capecitabine in TNBCs with
What,
residual disease after neoadjuvant chemotherapy.
Using PCR, right?
And yes, and that
Yeah.
had not shown any benefit of the platinum. So actually, we should extrapolate that, and that is what this trial has also shown, that in the adjuvant setting, platinum has really not given any much benefit. And part of the reason, possibly, I was just reading, is that platinum in TNBCs in the neoadjuvant setting, they induce antigen release, help in TILs and all that, which translate into PCR and the benefit. Whereas in the adjuvant setting, since the primary tumor has been removed, possibly these immune-mediated effects of the platinum may not be there.
Okay, Suman, the question to you is that will you give platinum in adjuvant therapy or not? Young
Probably,
patient.
no, probably
Young
in
patient has
adjuvant.
BRCA mutated.
So probably in adjuvant, no, but in neoadjuvant, definitely yes, irrespective of the BRCA status. I
So
would
young
offer.
patient and BRCA mutated in adjuvant you will not give. Is that right?
So
Can I come in, Chirag sir?
Yes.
There was a beautiful abstract by Koreans actually in the last ASCO actually, and it was Pearly, if I'm right. And there had a 15% of odd patient who had received in adjuvant setting. And in the forest plot, they did find that adjuvant carboplatins or platinums helped actually. And looking at the to erring on the statistical, even the hazards look much better. So we have to look Dr. Sudeep's data along with the Pearly, which is a Korean data set and much larger data set actually. And they did have, although a smaller number of patients, but I can tell you that it is a 125 patient lot in the 400 patient, not smaller. A 20% of patient lot who benefited from adjuvant carboplatin. I think for me, after that, I look into the ASCO 2024 data. I have actually added platinum into my adjuvant also in triple negative.
I agree. I agree with that, Dr. Sahu, that yes, there is a good data in adjuvant also, and especially our patients who do not afford immunotherapy, we should give them platinum, and toxicity is not that difficult. We give platinum left, right, center as medical oncologists, so should be given if it is possible to give in adjuvant also.
So Amol,
I just
Amol, which patient in neoadjuvant you will not give platinum?
No, unless there is a contraindication for platinum.
And contraindication like?
If there is a hypersensitivity reaction to platinum or the patient has a nephropathy, the same way we have a contraindication for platinum in urinary bladder, the same. Of course, we don't have similar criteria like the Gelskis criteria, but if the patient has contraindication of platinum, we will not give. Otherwise, there is no question of not offering it.
And there is a wonderful paper of giving dose-dense chemotherapy, 37,000 patient meta-analysis from Oxford. If we are giving 2 weekly chemotherapy, dose-dense chemotherapy, then the results are better as compared to the other modalities of giving chemotherapy. So, will you incorporate platinum here as well, or not in this subset where you are giving dose-dense chemotherapy?
Yes. So, of course, giving platinum as a dose dense becomes difficult. And generally, we give it 3 weekly, not as a dose dense.
Right. So when you are not giving immunotherapy, try to give platinum always as neoadjuvant therapy, unless there is specific contraindication to neoadjuvant platinum. And for adjuvant, we don't have data strongly for giving or not giving platinum. So from here,
I just had one question, sir, that if we find a patient to be BRCA positive,
yeah,
would we consider adding platinum in the adjuvant setting?
I will want to, yeah, correct. I will want to give. No strong data, but I will want to give.
So basically, platinum is a poor people's PARP inhibitor, and platinum is probably poor people's pembrolizumab in PNBC.
Correct. So now let us move to the remaining 5 to 40% of the patient in our practice. If we look at the ESMO guideline of last year, T1A or T1B don't give neoadjuvant therapy. Go for surgery and give appropriate adjuvant therapy. For T1C, I think let me look at the next slide. And less than 1.5 centimeter surgery as the first intervention, 1.5 to 2 centimeter neoadjuvant therapy without immunotherapy, and more than 2 centimeters or not positive. Now, most of the recommendations, most of the guidelines are taking keynote 522. So, Amal, do you agree with this algorithm, particularly for 1.5 to 2 centimeter?
I generally, in my practice, I keep the cutoff of 2 centimeter. Anything more than that, I go for anesthetic. Otherwise, I let the surgeon operate. But most of the time, I don't get opportunity to do that because most of my patients comes to me after surgery only.
So Chetan, no immunotherapy for 1.5 to 2 centimeter. Do you agree with that?
I think that's a fair call. But in my honest opinion, for India, this is splitting hair. 1.5 to 2 centimeter, most of our patients are not screened population. So very few of our patients are actually in that narrow range. Majority of the patients are either very small tumors, less than 1 centimeter, or clear cut more than 2 centimeter, or node positive. If I have a patient who has 1.6, 1.7 centimeter tumor, but there are axillary nodes and which are FNAC proven, I will probably go ahead and give push this patient for pembrolizumab addition in the neoadjuvant setting. But apart from that, if it's just 1.7, not much of a no nodes, nothing seen on PET or nothing felt clinically, I'll probably hold on. But honestly speaking, such patients don't even come to me for NACT. As Amol also was saying that these patients are often operated upfront and we get them for adjuvant chemo.
So Suman, do you get
I always say these patients are conference patients. They are only seen in conference.
Agreed. So Suman, do you get the patient with a less than 2 centimeter tumor for neoadjuvant therapy?
They do. The surgeons do send, at least in our center, the breast surgeons are at least that way. They find they do send. For NACT, again, for 1.5, less than 2 centimeters, I will not offer immunotherapy, but definitely I will give them the option, especially there is data for PT1C offering neoadjuvant. I would offer neoadjuvant in such patients.
So as we go down the line, we will keep on looking at data other than KN522 as well. And we will also look at what biomarkers we can have and can we escalate or de-escalate based on the PCR status. So NeoTrip PDL1 was not a very good trial, just 4 cycles of neoadjuvant chemotherapy with immunotherapy, just 280 patients, no difference in the PCR rate. But Keynote 522, 1100 patients, 8 doses of immunotherapy before surgery, 8 cycles of chemotherapy with carboplatin, paclitaxel, and anthra and cyclophosphamide. And we can say that there is a difference of 14% in the PCR rate. For the PDL1 negative also, there was a good difference in the PCR rate. This is an important slide, and I will come back to this slide little later as well. In IS6, now we have IS7 as well, interim analysis 7, where there is a difference of 9% at the end of 5 years. If you look at the difference between the two cups on your right side, for those who had PCR and for those who did not have PCR, the treatment is the difference is much wider for the patient who did not have PCR. And I will come to this point a little later as well. JEPAR Neo is an interesting study with 174 patients. Durvalumab in window of opportunity, which was subsequently removed after 117 patients. And then nab-paclitaxel with durvalumab without platinum over here. Clinical response, patient goes ahead with EC 4 cycles with durvalumab or placebo, and then surgery, and then no further immunotherapy. And there is a small difference between the PCR rate, which was not statistically significant. But if we look at the IDFS, DDFS, as well as overall survival, up to 5 years, the difference was significant, and that resulted in this particular publication in 2022, that even without continuing immunotherapy beyond surgery, the patients were having a better survival. So I will come back to this point once again a little later. So I am patient 031, 333 patients, Atizo Nab-Pacli, followed by Atizo AC versus placebo and chemotherapy, followed by surgery. And there was very good difference in PCR rate. So Amol, why did this regimen pick up in practice and in the guidelines?
Oh, you're asking the question why atezolizumab based regimen didn't pick up in practice. The answer is that's what you're asking. Unfortunately, my opinion is very clear about this. According to me, it's a weaker IO drug, and it doesn't work in any of the cancers apart from HCC, where probably it works because it has bevacizumab along with it. That's it.
Right. So this was the paper that was published in San Antonio this year. There were two groups working together on this particular trial. Platinum with paclitaxel with atezolizumab, and then atezolizumab with AC or EC, followed by surgery and atezolizumab. So exactly like Keynote 522. And if you look at the data, good PCR rate in EFS, which was the primary endpoint. Uh, so if you look at some of the highest risk patient with nodal status positivity, the p-value was 0.007. The HR was 0.623. With tumor more than 3 centimeter, the hazard ratio was 0.653, and p-value is 0.018. And TIL category more than 30%, rather less than 30%. The hazard ratio is 0.551, and the p-value was 0.023. But if you look at the overall, the HR was 0.805, and p-value was not significant, 0.093. So Amol has already given his statement about atezolizumab. What about you, Chetan? What do you think is happening with atezolizumab?
My experience with Atizo is similar, that it probably in breast cancer it is still underutilized. We'll probably see more of it once we have easier access.
So
And
Nitin,
then there will be
this meeting is getting recorded.
yeah.
Yes, I know. And we'll probably get more and more biomarkers. Now they have started, PDL1 is PASA now. Now it's still some other biomarker will keep coming, and we'll keep getting something from Atizo. They'll keep
So we'll come to that.
something
We'll come to
out
that.
of Atizo.
Nitin, so we have two different opinions. One, Atizo is a weaker drug, and Chetan is telling that Atizo is underutilized. So what do you think? What do you think about?
Yeah, so actually in clinical practice, Atezo in metastatic TNBC, we have seen good responses. But again, I will sort of sit on the fence and say that given how it has fared against other IO drugs in most other settings, also because of the fact it's PDL1 competing against PD1, we always feel PDL1 is a little bit weaker as compared to PD1s.
So Suman, direct question to you. I'm asking for your advice for one of my patients. The patient is avoiding. Should I use Pembro or atezolizumab?
Pembro, I hope there's nobody from Roche sitting here, but I think atezolizumab is the most useless IO immunotherapy that has come out. It has not benefited except for HCC. It is useless in every setting. Maybe biomarkers, maybe we need to select our patient, but as of today, it is useless.
Right. So
Can I go back, Chirag sir, one slide?
Yeah.
That one slide which you showed the subset.
Here.
Yeah, just so I want to ask Amol, the P for interaction is significant only for one, and I'll take the nodal status, and others can pitch in. And if you look at the nodal status and look at the P value for significance, the interaction is significant. So that part we cannot neglect as such. So I'm not questioning that 522 should not be the go-to because it met its primary endpoint. This did not. That's point taken. But the argument's sake, look at the nodal positive and negative, and you look at the p-value and the hazards, and the hazard is sitting exactly at where 522 is. So if there is a patient with a nodal positive, triple negative, will anyone be wrong in giving Atizo with this protocol of NSA-BP B59? I hope my question is clear to the panel.
So my answer is this, Dr. Sahu. In India, nobody is wrong of doing anything.
No,
there is
no,
some
no,
data
no,
for
no,
there is some
India.
data for everything. There is
No,
some data for everything.
The P for
What is the
interaction
point
is
is
positive here.
Let me answer that.
Yeah.
So there is some data for everything, and as you have pointed out, yes, the P for interaction is good enough. But we have to look at the larger picture, and the larger picture is that I have one robust trial which is significantly positive for the primary endpoints. Why will I not go for that particular way rather than going for this way? Unless until I have some other
So I'm
reason.
looking at a very different. I told that disclaimer: the 522 is the way to go forward as per the level of data.
That should be the end of the discussion.
Yeah. So, but I think this is a very important part which
because we have a lot of residents in the audience. We should give a very clear cut message that which trial has the robust data as compared to which trial doesn't have. That's simple.
The other thing is, sir, that Pembro showed a benefit irrespective of the till levels. Whereas if you see in this slide, the Atezo benefit was there only when the tills were more than 30%.
No.
So again,
Nitin, the interaction was not significant. The only significant interaction was for node positive.
no, you look at the tills. No, you look at the tills.
What is the node status? What do you do with that? With the
See,
P for
again,
interaction
you have
positive only for
to
that.
you have to see whether it is a pre-specified subset analysis.
It is
whether
pre-specified. It was pre-specified. I've read this trial.
whether there was sufficient distribution of the alpha to get to this conclusion. So there are a lot of caveats into this, and when there are a lot of caveats, it's like you can torture the data.
Chirag sir, we can go on.
So one simple statement to come out of this issue is that when the primary endpoint of a trial is negative, we cannot look at the subsets with positive endpoints. So that's why we should not be using atezolizumab and we should be using pembrolizumab. Sometimes in future, if we find out the biomarker and we do a separate clinical trial, that's a different thing altogether. But otherwise, the pembro is the drug to go with. So, Nitin, if you miss to give immunotherapy and neoadjuvant chemotherapy, if there is PCR, it's fine, wonderful, nothing else to be done. But if there is no PCR, will you try to make it up with giving immunotherapy at that point in time?
No, sir. I just go by the Createx trial and we use sort of the capcitabine at this point of time.
Right. So A-Brave trial, if you look at the author's conclusion, 3 years DFS in ITT, HR was 0.81, DFS in neoadjuvant population 0.8. But here, 3-year OS in ITT population, HR is 0.66 and DDFS, HR is 0.7. And the authors have concluded that avelumab could have a role in treating patients with early TNBC and residual disease after neoadjuvant chemotherapy or high-risk disease after surgery and adjuvant chemotherapy. So, Nitin, what is your point? What is your take on this numbers and then this conclusion?
But sir, again, when you look at sort of the confidence interval of the DFS, both in the neoadjuvant and the intention to treat population, it's crossing one. The p-values are not really significant. Again, with regard to the OS, whether any subsequent treatment was used which impacted it is something which we will need to know. I'm still not very convinced by the usage of adjuvant avelumab in this setting.
So for that matter, we can say that adjuvant, if you miss to use the neoadjuvant immunotherapy, don't try to make it up by giving it in adjuvant setup. And we need to have a more trial to say that, I will go ahead and I will use immunotherapy. Is that correct?
Yeah, absolutely.
Perfect. So I am patient 030 was not a very good trial. So this trial also, if we didn't use any neoadjuvant therapy, then shall we give adjuvant chemoimmunotherapy or not? The trial clearly says no. Whether now, Amol, it is because of using atezolizumab. If we had used pembrolizumab over here, would it have succeeded?
I don't think so, because
Okay, good.
unfortunately, in the adjuvant setting, the tumor is not there. So with it to have those kind of neoantigens and the TILs for the IO to work is not there. But what is important is to understand that such trial was not designed by Pembro in adjuvant setting, because probably those guys are smarter and the other guys are not smarter. So they end up doing these trials and end up increasing the negative trial list.
So better way to give adjuvant or neoadjuvant immunotherapy is to give it in the neoadjuvant setting rather than the adjuvant setting. Is that correct?
Correct.
Yeah,
Correct.
perfect. So if you look at biomarkers quickly, this trial looked at a number of biomarkers like T cell inflamed, 18 gene expression profile, tumor mutation burden, non-T cell inflamed GP, and then TNBC, molecular subtypes, HRD status, and so on and so forth. And there are several slides which I have skipped for the interest of time. If you look at the TNBC molecular subtypes, we were thinking that inflamed subtypes, immune subtypes will have a better outcome. But if you look at the conclusion, in every subtype, the drug worked and it had the better outcome as compared to a placebo in terms of primary endpoint as well as the overall subgroup analysis. So, any comment on that, Chetan?
I think it has shown benefit across all subgroups, irrespective of any of these. So today, that is the go-to therapy. So,
Right. And Suman, it means that at present you will not want to look at any further biomarkers. Is that correct?
At the moment, I think all
At the
subgroups
moment.
showed, except for RCB3, I think everybody, whether you were PDL1
Yeah.
positive, negative, whatever the node status was, it showed benefit. So probably, I would not look for further biomarkers.
Suman, we have at least two Marathis over here. Dil gud ke laddu ke liye. So, what will you take on TILs? The TILs is the I mean, one very basic question: whether TILs are easy to assess or difficult to assess?
As per what the pathologist told me, it is really difficult to assess because they have to count a number of cells, and I think it's a really big task to do it. So, and at the end of the day, how good is your pathologist to give you the TIL also? So I don't know. As of now, I think it's technically very difficult. So I don't know how, I mean, until and unless we have an easier method to do it or a very good pathology department, I think this is going to be very difficult.
So, Nitin, have you discussed that with your pathologist, whether it is easy or difficult to look at TILs?
Yeah, so it is definitely not easy, but I mean, they say that there are standardized guidelines. So basically, they there are two types of TILs. One is the stromal TILs, and then the intratumoral TILs. So most trials and most guidelines are looking at the stromal TILs, so to speak. It is challenging, but they are doing it. They are reporting it from a prognostic point of view. But yes, it is time consuming. And I think moving forward, I think AI and digital pathology is going to make it much easier.
We
Great.
have to ask for it actually specifically if we want to tell. They don't give it upfront. We have to ask for it if we need it.
Absolutely, absolutely. Chetan, what is your experience?
I have a different take that probably we still don't know the cutoff, how many TILs are significant, which TILs are significant, whether stromal, intratumoral. So that right now it is a very, in my opinion, not a very well standardized biomarker. So as of now, I don't ask for TILs in my practice. Whenever the indication as per data is there, I go ahead with immunotherapy and I don't go for the TILs at all.
Right. So, Amol, you have pushed your pathologist and they have now started giving you TILs. Your patient had a PCR and you and your pathologist and your patients were all very happy. But then pathologist comes back and tells you that the TILs are less than 30%. So, what will your reaction to that? How will you work on that?
So honestly speaking, my pathologist struggles to get HER2 0, HER2 1, and HER2 low only. Forget the TILs. But if we assume in an imaginary situation, my pathologist does the TILs and comes back and tells me less than 30%, I will say, fantastic, thank you very much. But I will not rely on that report because my pathologist, you require a validity of that reporting, you require a robustness in the reporting. That is not there, and hence, again, I said TIL is a conference biomarker. Outside conference, it doesn't exist.
Okay. So let us talk about conference discussion only. Let us continue with you only. That if you did it in one of the central reference laboratory, one of the very good laboratory, and that laboratory tells you that TILs are just 12%, and patient was clinically node negative or clinically node positive to begin with. So will you escalate the treatment looking at the TIL value of 10%, and if the patient was not positive to begin with?
Yes, there is a data, and if you have a standardized results to show that the TIL value is less, there is a data, but it is not a robust data as of now, and I will not implement it to my practice as of now. If at all patient is anxious, I will discuss the data and have an informed decision, but it's not standard of care as of now.
Right. So we might look at enrolling the patient on the clinical trial if we have one, but otherwise with PCR, you will just continue with pembrolizumab for remaining months of completing 1 year. That's correct?
Yes, and in fact, if the patient has a PCR and a patient has financial issues, I will discuss whether you want to de-escalate and stop pembro or reduce the duration of pembro. But the TIL discussion is too difficult to integrate into clinical practice as of today, unless we have a robust data.
So I will not ask any question on this particular paper. There is an oncolytic virus. If the patient has residual radiological tumor of more than 1 centimeter, which is confirmed by the biopsy, the virus is pushed along with atezolizumab, and then the surgery is done. If the patient has a PCR after surgery, the 4-year survival rate is 100% as compared to 77.4%. Just a very small trial, 28 patients only. So it's more of a brainstorming trial rather than actually putting in the clinical practice. Now, if the patient has this point we were discussing earlier, and a quick question to the panelists, and then we will go ahead. 22% of the panelists in Stan Galen 2025, before a couple of months, they said that with tumor of less than 2 centimeter, just 22% of them said that they will give neoadjuvant chemoimmunotherapy. But the same question was tweaked and said that if the patient has a tumor of 1.74 centimeter, then 46% of the patient, 46% of the panelists said that they will be giving chemoimmunotherapy. So starting from you, Suman, why do you think is that there is a discordance in the response on the similar question?
Sir, I actually went through this whole presentation. It was a very interesting presentation by Dr. Elizabeth. So she also said, the oncologist just got confused when she just tweaked the question. I think it was the size. From 2 centimeters, she made it 1.7 centimeter, just changed the question and the oncologist got confused. And I think this is what happens in clinical practice as well. She also made a very interesting point that in the keynote 522, more than 50% of the patients post NACT without pembrolizumab actually achieved a PCR. She also said that 88% of the PCR people who achieved it without IO actually had a relapse-free survival at 5 years. So she made a point that, when you give pembrolizumab and you don't get a PCR, 40% of them actually relapse. So at the end of the day, you have to really select your patients of who will do fine, and the game is PCR at the end of the day. You have to achieve PCR, whether it is with chemo, whether it is with chemo plus IO, whichever way. That is the only way forward, is the PCR.
Right. So number of trials are enrolling the patient with stage 1 in
Chirag sir,
NCI.
just if you can go back one slide. Yeah, so here I think it was not another tweak. She added lot of high risk features. That's where people change. She put a very healthy young woman. She puts high grade,
high
which
grade,
was not there in
high risk.
the upper question. So these
Yeah.
two would have swayed the oncologist to go for what
Possible.
it is. So that's one small thing.
Possible.
But yes,
But this point
people
was
are
discussed
confused.
adequately
But she
earlier,
said,
so I'm not
yeah,
going to discuss again.
all her oncologists got confused is what she actually said.
Right. So these trials will answer whether we should give chemoimmunotherapy to the patients with stage 1 TNBC or not.
Sir, just one thing, that one slide which you put of all the slides, the one interesting study there is the Bellini, which is using Nivo and EP in patients with high TILs and avoiding chemo. So that is an interesting study to look forward when the complete results come.
Absolutely. Perfect. Yeah. So going forward, how to de-escalate or escalate. So in JPAR Nivo, as I just said already.
Sir, 5 more minutes, sir. We'll stop.
Yeah, sure, done. The difference in the survival at the end of 5 years was 8.4%, 8.4% even without adjuvant immunotherapy, while that in KN522 was 7.7%. So what is the advantage of giving adjuvant Pembro? That is the question to be asked. And we need specific escalation or de-escalation trial to define optimum post-NSCT adjuvant therapy. So there are de-escalation trials for the patient with PCR, and then there are escalation trials for the patient without PCR. So these are just ongoing trials, and we don't have any answers to these particular questions. Of Pembro is Pembro versus observation, and optimized PCR is again the same thing, Pembro versus observation for the patient who had PCR to neoadjuvant chemoimmunotherapy. The it is important to look at residual cancer burden. And for RCB 1, 2, as well as 3, many of the patients, irrespective of whether they have been given pembrolizumab or not, they keep on having a recurrence. So there is need for escalation to these patients. And single agent treatment for low cancer burden and previous toxicity, access and availability issues, and increasing RCB is having dismal prognosis features, and combined treatment has to be given. So these are the recommendation of ESMO as well as NCCN to consider capecitabine and pembrolizumab on individual basis. And for BRCA1 or 2 mutant, ESMO guidelines considered on individual basis combination of olaparib and pembrolizumab, while NCCN do recommend sequential or combined use of olaparib and pembrolizumab, while none of the guidelines recommend usage of olaparib and capecitabine together. Then there is a planet trial of Fembro versus Pembro with capecitabine. There is a CAPAN trial, the same design, and there is SASIA trial of sacituzumab for a patient with residual disease, and ASCENT 5 study of Pembro and sacituzumab for patients with residual disease. I think this is my last slide. So thank you very much, Sahu, and thanks to all the panelists. Thanks, Amol, Chetan, Nitin, and Suman for a wonderful discussion, and thank you very much. Thanks,
Thank
everyone.
you. Thank you.
Thank you, sir.
Anyone wants to say something? If not, I think we had. I've been answering this question Q&A, and I think most of the QA has been answered. There are a few Q&A. I will ask 2 or 3 of panelists who are there, Chetan or Suman and Nitin. So there is one question about EFS improvement in non-PACR patients in KN522 is due to neoadjuvant Pembro or adjuvant Pembro. So Chetan, will you take this? The event-free survival benefit that is in non-PACR in 522. So what do you think? It was due to the neoadjuvant component or adjuvant?
I think it's because of the neoadjuvant component.
I feel you cannot answer both, but once the PACR is not achieved, as Suman was pointing out, it's a poor prognostic factor. But I think there was also a data set which has shown that the continuation of adjuvant Pembro did add more except for the RCB3, but it was not statistically significant. So I don't think there is a direct answer. But yes, people are looking into. Nitin, you want to say something on this? Hello. Okay.
Yeah. So I think I think that it is more to do with the neoadjuvant component itself, because again in most trials we see that immuno works best in the neoadjuvant. So I think the benefit is still because of the neoadjuvant component, and perhaps continuing it is there is, again, I'm just speaking on a very theoretical sense, that you're keeping the immune cells activated to clear off whatever residual tumor cells may be there in circulation.
But there is no direct answer to this. Probably we'll get answer in the future. So in adjuvant, what's the role of immunotherapy? I think that was answered, that yes, there is no level 1 evidence. There is a break which we discussed, and there are fallacies in that. It's a negative trial. So one more question which Amol or Suman can answer: whether to finally omit adjuvant carboplatin based on the NRG data, even in node positive TNBC. So if someone has not received neoadjuvant, and would you add adjuvant carboplatin? Suman, you told no. Would you think in a high node positive you would try to give that? And look at the which I told, look at the Korean trial in 2024. There was some 28% of patient, 125 patient, and it was a positive trial. Suman, your take on that?
Sir, I mean, you did mention about the Korean trial, but in the NRG specifically, there was no improvement in the invasive disease-free survival. So probably.
Okay, fine. So I think people have to, the answer is not yet out. There will be further data set, but also look at the Pearly trial, which is a phase 3 randomized, much bigger than the TMH trial. And it was positive. And there one difference between TMH and Pearly, if I remember correctly, because I did the moderation last ASCO on this, was that there was no difference, as the TMS told that the postmenopausal does not benefit at all from the carbo. Here there was still a benefit in the postmenopausal. So there are subtle differences in the interpretation of the new TMH and the Pearly trial. So there is one more question which probably Amol can take it. Amol, what is the relevance of Createx data in case of platinum addition in the neoadjuvant chemotherapy? I'll put it more so. So Createx, if you do not achieve a PACR in the adjuvant setting, will you add capecitabine to Pembro?
So the answer is, if you're not achieving PAT CR, even if you're given adequate NSCT along with IO, you have to do something more. And that something more as of now is, of course, you can add the capecitabine data after discussing with the patient, because that is the only thing which has shown OS. CAPEX trial has shown OS. So when I have nothing else to work on, unless some ADC comes, maybe Sacituzumab govitecan comes in an adjuvant setting, I will keep on adding what I have.
So actually, in the authors also has written that in the full text that there is no data which they wanted to look at, because this was much later and this was conceived much earlier. But they do tell that there are other data sets in other tumor sites where capecitabine with pembro was tolerable and you could do it. So last question, probably Chetan and Nitin. If you have a PAR positive and you do not have a PATH-CR achieved with the immune checkpoint, like in 522, how would you sequence your olaparib and capecitabine and pembro? Chetan, I hope you got the question right.
Yeah, I get it. So you have a patient with residual disease, patient
And
is
PAR
BRCA
positive and
positive,
BRCA
and
positive.
yeah, BRCA positive and
received on 522.
Yes, and has received NACT as per keynote 522.
Yeah.
So I try to give benefit of everything because I know this subgroup is bad. There is a very high chance of relapse because of these various reasons. I try to put in sequentially olaparib and capecitabine. I typically begin with capecitabine, and then after 6 months of capecitabine, I start my olaparib and go on for a year. If the patient has problems in tolerating capecitabine full dose, I try to give at least the lowest I go is 3 tablets morning, evening.
825 per meter square is something which you
Yeah,
like.
at least 1 gram per meter square. If the patient has less than that, then I
So
stop.
basically, Chetan, you are going to give importance to Createx, complete the adjuvant capecitabine with pembro, then go for olaparib.
Go for olaparib.
That's what it is.
Yes.
If you have to choose one, Ola versus Cap, what would be your go-to?
Probably for BRCA positive, I'll probably go for olaparib.
Yeah.
Nitin, any
Yeah,
difference?
same thing, sir. Would possibly go with olaparib with pembrolizumab.
I think
as the
our
option.
moderator also supports that, and basically the thinking is the question also comes with abemaciclib and olaparib. The point is you have a target here. I think that is what is pushing, and you have a data which is positive for even prolonged for Olympia. There was one question on the Pearly data which I really put up. And actually, to answer that attendee has asked how many patients received adjuvant platinum only in Pearly. If I'm not incorrect, it's 25 to 30%, and the patient pool was around 500 patient odd. So around 150 odd patient would receive the adjuvant. So it's not a small number. So that is all. Is there any other questions, Tarun? I think we have answered most of the relevant questions. There are some other questions which are not relevant. I think we can just really get into that. So any last words from Chirag sir or any other panelist?
Thank you. Good night.
Okay.
Thank you.
So thank you all. Thank you for staying back late. And tomorrow we start at 7, and it will be much more on the Destiny 09. The showstopper will be there for us tomorrow. I think that's what the ASCO 2025 has really brought about, and will be the most discussed abstract actually. So let's see what our moderators have to say on that. So with that, I would like to thank all the panelists, all the moderators, all the faculties, all the attendees, and Tarun and his team for giving this up. And this was purely a scientific endeavor. We do not have any sponsored session, no support. So this is what it should be. Sciences should be more discussed freely. And thank you all for giving me the time. So we meet you tomorrow at 7 for the day 2 and the last day of the Best of ASCO and ESMO Breast 2025. Thank you.
Thank you,
sir.
So thank you, Dr. Sahu, for wonderfully moderating ASCO and ESMO 2025 on behalf of the team, Aram and Yashika, from all of us. Thank you so very much. We log in again tomorrow, sharp by 7 p.m. Till then,
bye.
Stay safe, stay blessed, but please, percolate to the students to join tomorrow.
Yeah.
Thank you and good night.